amino acids. Sulfuric acid is produced by the metabolism, and phosphorus containing compounds like phosphoserine also, their metabolism produces sulfuric acid, and also other organic acids are produced, and they must have to be eliminated by the kidney, and their amount approximately 50 to 60 millimole, millimole or milli equivalent of hydrogen ion. It is eliminated through the kidneys primarily. But this huge amount is eliminated through the respiratory system by the process of ventilation. And from your knowledge, you can easily calculate this value from your expired carbon dioxide elimination per minute. pH of arterial plasma is 7.4. 7.4. Nanomole per liter. From the pH value, nanomole per liter can be calculated by the formula antilog 9 minus pH. Antilog are at any pH. And at pH 7.40 is 40 nanomole per liter. And life is possible within a narrow range. pH 7.0, 7.7. And within this pH, life is possible. Beyond this, it becomes impossible. And kidney is the important organ to eliminate this fixed acid, sulfuric acid, phosphoric acids, and other organic acids that can be produced in different physiological conditions. It depends on diet also. Yeah. Proximal tubule, distal tubule, and distal and other parts of the distal nephron all has the capacity to eliminate this hydrogen ion. In the proximal convoluted tubule, hydrogen is excreted primarily by the secondary active transport with a sodium hydrogen exchanger mechanism. Secondary active transport. And bicarbonate is reabsorbed. Yeah. Bicarbonate. Bicarbonate concentration in the plasma, it is 24 milli equivalent millimole per liter. Bicarbonate concentration. So you can calculate the filtrate load of bicarbonate. Normally, all the bicarbonate is reabsorbed. In health, urine does not contain much bicarbonate ion. Completely reabsorbed, primarily from the proximal tubule. Proximal tubule. And it may be asked in the examination how the proximal tubule secretes hydrogen ion and reabsorbs almost all of this bicarbonate load. And if you see the simple figure, luminal site, and it is the ISF, interstitial fluid, and it is the renal tubular cell. From the luminal side, there is sodium ion and bicarbonate anion. It is coming, and filtered load per day is 180 multiplied by 24 millimole per day, where the GFR is 180 liter per day. এটার কত হয় বার করে নিতে পারো, 4320 মনে হয় হবে, বার করে নিতে পারো। Now this sodium ion is exchanged, sodium ion exchange with the hydrogen ion, and this hydrogen ion is derived from carbonic acid within the cell, and in the proximal convoluted tubule epithelial cell, like the parietal cell of gastric mucosa, contains carbonic anhydrase. Carbonic anhydrase enzyme quickly converts carbon dioxide into carbonic acid, CO2. It is the gaseous state, and H2O with the help of carbonic anhydrase, H2CO3. And it splits into this, and another is HCO3 minus. And it can diffuse into the interstitial fluid and ultimately enter into the blood. Or there is exchanger, band 3 protein. It is eliminated against the chloride ion. Band 3 protein. Now, what is the fate of this in the hydrogen ion in the lumen and in the brush border area of the luminal side of the proximal tubule? They also contain carbonic anhydrase, and it when it comes and it will CO2 then enters into the cell to be eliminated, either removed in this way or have its fate in this way. Here. So the amount of hydrogen ion that coming through the proximal tubular epithelial cell, it is the proximal tubule, and it reacts with the bicarbonate ion to form H2CO3, and in the brush border area or microphilous border area of the proximal tubule, there is carbonic anhydrous, but it is absent in the distal tubule and distal nephron. Okay. And it is quickly converted into carbon dioxide in the reverse way, into carbon dioxide and water. Water remains in the lumen, and carbon dioxide can diffuse easily through all the biological membranes, and it may be either eliminated through the cell within the blood, or it may take part in the same reaction. So ultimately is that there is loss of one bicarbonate in the lumen, but another bicarbonate ion is taken in, though it is not the same molecule, different molecule. Ultimately there is net transfer of this bicarbonate ion. Clear? And in this way all the bicarbonate is reabsorbed. All the bicarbonate reabsorbed and filtered load, and in this case it is millimole per day. এটা গুণ করে দেখতে পারো, ভুলভাল লিখলাম কিনা, বুঝতে পারছো? এটা সমস্তই রিঅ্যাবজর্ব, শোষিত হয়ে যায়, and fall in the pH within the lumen of the proximal tubule is minimum. At the beginning of the process in the Bowman's capsule, the pH is equivalent to that of the arterial plasma, 7.4. As most of the hydrogen ion is annihilated in this process, so at the end of the proximal tubule there is only moderate fall up to 6.9 or so, up to 6.9 or so. The distal part of the nephron, especially in the distal tubule, connecting tubule, collecting ducts also, in that case there is less amount of hydrogen ion is eliminated, but the fall in the pH is more, and we have to eliminate this amount to see, and pH of the urine can vary from 4.4 in textbook, in some 4.5 it is written, and up to 8.0. It is the urine pH limit. Maximally acidified urine and maximally alkalized urine, this is the range, and when it is 4.4, then it is 40 nanomole per liter, and it is 1000 times than this value, 1000 times than this value. বুঝা গেল? pH 7.4 and pH 4.4, and there is increase in 10 to the power 3 times. 1000 গুণ হাইড্রোজেন আয়নের ঘনত্ব বেড়েছে, এটা নিশ্চয়ই সবাই বোধগম্য হয়েছে। ক্লিয়ার? এটা বুঝতে কোনো অসুবিধা আছে কিছু? হ্যাঁ, যদি থাকে বলো, তাহলে পরে আমি এটা দেখতে পারি। সব স্কুল পাঠ্য ব্যাপার এগুলো। যেমন 7.4 যদি হয়, তাহলে পরে 10 to the power -7.4 মোল পার লিটার, মোল পার। And maximally acidified urine is 10 to the power -4.4 mole per liter. If you divide this value with this value, then it becomes 10 to the power 3, 10 to the power 3. And if you know this value, 40 nanomole per liter, so 1000 times this value, and it is grossly inadequate when you have to eliminate 50 or even 40 millimole per liter. It is grossly inadequate. বোঝা গেল? হ্যাঁ, বুঝতে পারনি? তাহলে একটুখানি সিম্পলিফাইয়ের জন্য আমি এটা বলে থাকি, এগুলো স্কুল পাঠ্য জিনিস তো, এগুলো এই জন্য। এই যে 10⁻³ তাহলে এই 40,000 nanomole per liter. Nanomole, mole per liter. Mole per liter. So this value is grossly inadequate if you consider this value as 40 milliequivalent per milliequivalent. Mole per liter. So this value is much more than this value. Much more. So if an individual is to eliminate not 50, even less than that, for the ease of calculation, this mole per liter is eliminated, and maximum acidified this value. So you can find out what should be the value. Thousand liter. So 1,000 liter of urine is to be produced per day to eliminate this. So that maximally acidified urine is not adequate to eliminate the hydrogen ion produced by the metabolism, that has to be eliminated by the kidneys. And here is the role of the urinary buffers. Urinary buffers. It is important for the examination. 3 buffers you have to consider. One is bicarbonate buffer. Bicarbonate buffer. Bicarb. Another is the phosphate buffer. Another is the ammonia buffer. Ammonia. Ammonia buffer. Bicarbonate buffer is important. Phosphate buffer, ammonia buffer, and ammonia buffer is more important than phosphate because its concentration is low. Phosphate buffer. Buffers within our body are weak acids. Weak acids, what is the difference between the weak acid and strong acids? Strong acids in dilute solution completely dissociate. Completely dissociate. But the weak acids do not. They dissociate incompletely. So their solution contains 3 components: undissociated acid, hydrogen ion that may be considered as protons, and hydroxyl anions. All 3 elements, they have their existence. Suppose in a buffer of HA, minus, and in its solution, weak acid, dissociation is incomplete, and so it contains this component, undissociated acid, hydrogen ion, and this anion. They are present. Suppose in this case, if an alkali is added, then alkali is KOH. It is a strong alkali and it's completely into hydrogen, so that initially the hydrogen concentration and the pH is tend to rise, but it is to some extent prevented by the further dissociation of the undissociated acid. Or if a strong acid, its small amount is added, then it will react with this, and the reaction will be this side, on this side. So increase in the hydrogen concentration in that case is not so that is expected, and it is the buffering property, so that the pH is maintained constant. And in case of the buffer system in general, by Henderson-Hasselbalch equation, any buffer system, not to the base 10, and these buffer systems do act. Phosphate and ammonia buffer, that is, it is produced from glutamine by glutaminase enzyme. Within the cells there glutaminase enzyme is present, mitochondrial enzyme is present in the proximal nephron and also in the distal nephron. It gives rise to glutamate and this ammonia, and ammonia will have to react. It is present in the proximal tubule also, and ammonia is freely diffusible through all the biological membranes. So whenever it is produced within the cell, ammonia, suppose ammonia is produced from glutamine, and it has a tendency to enter in this way and also in this way. And whenever NH3 comes into the lumen, it will react with hydrogen ion and forms NH4 anion. NH4 cation. NH4. And it is eliminated as ammonium chloride also. It is when it is available, they are available. Sodium chloride, it is eliminated in this way. And when it is coming into the lumen, it is converted into NH4 plus, and it cannot return back into this direction. Ammonia is freely diffusible, but ammonium ion, that when that is formed in the, either in the interstitial fluid or in the lumen, then it cannot turn back. Turn back. Because it becomes ionized and is surrounded by water molecules, it will not come out. So it is called non-ionic diffusion or a diffusion trapping. Non-ionic is an example of, good example of non-ionic diffusion or diffusion trapping. Some weak acids, organic acids also, or weak alkalis, weak bases, they can pass through the lipid membrane. They are soluble in the lipid membrane, But when it goes into the watery part, in the lumen or so, and then if there is suitable atmosphere, it can be converted into either protonated form or basal form, non-protonated form. And that form is surrounded by water molecules and it will not turn back. It will remain there. It is called diffusion trapping. And some drugs and even poisons may be of this nature. And when it comes into the lumen, then it is converted into this type of compound so that it will not turn back. So in some cases, it is utilized. By either alkalinizing the urine or acidifying the urine, it is done. It is called non-ionic diffusion or diffusion trapping. Diffusion trapping. The importance of that is that whenever there is chronic acidosis, then glutamine is synthesized in the liver in higher amount, more available. But the phosphate concentration that is present within the plasma is relatively fixed. So that though it is a good buffer, its power is limited. In case of ammonia buffer, and in that condition we have to consider that this power of a buffer system is maximum when this ratio is 1. That is pH is equal to pK prime, pK dash. Yeah. That is concentration of this anion and the acid becomes equal. So the pH is equal to pK. pH is equivalent to pK prime. Apparent dissociation constant. True dissociation constant requires complete non-interaction between the ions, and that is a theoretical concept. But in practical, it is there is the pK prime, the apparent dissociation constant is constant. And the buffer system is maximally effective when the pH of this surrounding is equal to that value. In case of bicarbonate buffer, it is around 3. But if you consider the case of carbon dioxide, in place of carbonic acid, then this apparent, it becomes equal to 6.1, and that is dissolved carbon dioxide molecular level, and it is has relation to that of the solubility of that and the partial pressure of carbon dioxide. So clinically relevant form of bicarbonate buffer is this is the value. Yeah. Not directly carbonic acid, it is carbon dioxide, and soluble form is in proportion to that of the partial pressure of carbon dioxide, and it is the solubility at that temperature, millimole per liter per millimeter of mercury of partial pressure of carbon dioxide, and it is the critically important form. by means of suitable electrodes, they can be known PCO2 and pH value, either arterial plasma or venous plasma, arterialized venous plasma, they can be known by the electrodes. And in this, so this can be calculated. And from your knowledge you can find out what should be the pH of the arterial sample, arterial plasma. বুঝা গেল? By the formula. It is 6.1. It is not very close to 7.4. In spite of that, it is an effective buffer because they can be independently regulated. Carbon dioxide by the lungs and bicarbonate by the kidneys. And there is a term, titratable acidity. Titratable acidity. When the urine is acidic, then by means of titration with strong alkali up to 7.40, we get the value of titratable acidity up to 7.4, and in that case the carbonic acid buffer is not measured, because this carbonic acid, that is hydrogen ion that is eliminated, it reacts with the within the luminal bicarbonate and is converted into H2CO3, and it is eliminated by the respiratory system. So it is not measured. So titratable acidity is also not applied to ammonia buffer. In case of ammonia buffer, pK prime is high, and so that its contribution is negligible when it is titrated up to the value of 7.40. Suppose in case of ammonia buffer, pH is equal to suppose 9.4. It is the protonated form, it is the non-protonated form. And in that case it is 9.4. So when it is 7.4 is equal to 9.4 plus log, and this value should be 1/100. So this form will predominate than the ammonia 100 times, so that it will not give up the hydrogen ion for the titration. So it is the phosphate buffer and other buffers, though they have minor importance, they are titrated. Phosphate buffer. Na2HPO4, this formula is like that. Acid phosphate, basic phosphate in this one. And in that case, the pK prime value is 6.8. Is 6.8. And it is close to 7.4. Or the media, close to 7, that is the luminal pH. So it is an effective buffer, but concentration is less. Suppose 1.5, it is present in the phosphate buffer, is present in both forms, 1.5 millimole per liter. Concentration is low, and more than 85% is reabsorbed, primarily in the proximal nephron. And so its concentration even becomes lower, but in the distal nephron, it becomes concentrated by the absorption of water. Whereas concentration increases, then it is effective buffer in the collecting tubule or collecting duct. And as the phosphate concentration within the cells is more, intracellularly it is an important buffer. So when it is up to 7.4, it is the provider of the protons for the neutralization process. So titratable acidity is almost equivalent to that of the phosphate buffer, acid phosphate. So in this case, it occurs mainly in the distal nephron, not in the proximal nephron, distal nephron. Distal tubule, collecting duct. In that case, phosphate is operating. And within this lumen, there is and in the distal nephron, this exchanger is not much effective, and it is by means of a proton pump or hydrogen pump, by means of which hydrogen is coming, and this hydrogen is coming through this hydrogen ion is coming, and sodium ion, one sodium ion is entering sodium ion, and it is converted into Na H2PO4 minus, acid phosphate. Monobasic, and there is this acid, it is the acidic form, this form. Its concentration go on increasing, and its pK value is 6.8. So it is an effective buffer, because the concentration ratio is approximately, this becomes 1, and in this way it is eliminated. Whenever it is 7.4, it is 6.8, then this value in this case is more than the denominator, roughly 4 times, 4:1. Whenever, in this case, this pH is 6.8. So when it is 7.4, four is to one, roughly. 4 is to 1. Log 4 is 2 log 2. 2 multiplied by 0.30, 0.6, 7.4. 4 is to this ratio. This ratio. And their valency can be calculated in this way normally. What should be the valence? Sadhuna 8 and 9. 9 by 5. Valence. So valence will be 9 by 5. 1.8 valence. In some text, they has been explained in this way. So our question is the titratable acidity. Titratable acidity is mainly the phosphate, acid phosphate. It can be titrated. And urine acidified urine can vary from 4.4 to 8.0. When it is more than 7.4, you are not considering. When the urine is acid, suppose it is 5.0 in an individual, then you have to know what is the titratable acidity. You can titrate it with potassium hydroxide also, and along with an indicator. You have learned the process of titration in your school days. And in that case, ammonia will not give up this hydrogen ion, because when up to the level of the 7.4, it is 100 times than this. Protonated form will dominate 100 times than the non-protonated form. So it will not give up the hydrogen ion in the process of titration. Yeah. But this phosphate, acid phosphate can give up. It can give up. And it is the titratable acid. Along with other smaller components like acetoacetic acid, beta hydroxybutyric acid, where this pK value is 4.8 or so, it can contribute. But in health, they are of little concern. In the proximal tubule, in this way bicarbonate is reabsorbed, and it is linked to bicarbonate reabsorption. Bicarbonate is reabsorbed primarily from the proximal nephron, when almost 10% is reabsorbed, and remaining part is reabsorbed in the other parts of the nephron, distal tubule, collecting duct, where it is dealt with. Now there is a term, that is bicarbonate reabsorption and new bicarbonate formation. New bicarbonate formation. Suppose if there is increase in the hydrochloric acid within the body, hydrochloric acid, it is possible if an individual takes ammonium chloride or calcium chloride by mouth, that is equivalent to add acid within the body, and this acid will react with, suppose, bicarbonate anion, bicarbonate process, it is converted into sodium bicarbonate, and so on. Now there is loss of this bicarbonate. This loss can be recovered by formation of new bicarbonate. That is coming in within the filtrate is recovered. It is reabsorbed. But that is lost by the process of titration within the body with strong acids, and that loss must be replenished by formation of new bicarbonate. And it is possible with this type of buffers, but it is a phosphate buffer and ammonia buffer. An ammonia buffer. Whenever it is bicarbonate buffer, this bicarbonate within the lumen is destroyed by the hydrogen ion coming in this way, and in relation to this, another bicarbonate molecule is reabsorbed. So it is the recovery. It is not the generation of the new bicarbonate. But whenever it is ammonia, or in this case, this bicarbonate is the new bicarbonate. New bicarbonate. And in that case, there is, this bicarbonate is a new bicarbonate in this case. In this case. Clear? You have understood? New bicarbonate. Whenever it is recovered from sodium bicarbonate, then it is the recovery. In that sense, it is reabsorption. Reabsorption. Clear? Reabsorption. But whenever there is the involvement of the ammonia buffer and phosphate buffer, the bicarbonate is not that it is recovered from the lumen, it is a new bicarbonate. So it is replenished in this way. In this way. This hydrogen is coming out by the process of active pump in the distal nephron, and it will react with this disodium monobasic phosphate to sodium NaH2 acid phosphate, and this bicarbonate that is generated, and it is not that of the in exchange of that, it is the new formation. It is only in this case, it is recovery, but it is the generation of, it is the replenishment, or it is the generation of new bicarbonate. So that has been lost in the process of titration within the body is made up. And there are some factors that can operate. Suppose whenever there is acidosis, from this formula you can have this concept, respiratory acidosis. Whenever there is increase in the PCO2 and bicarbonate remains constant, then it is called the uncompensated respiratory acidosis. Uncompensated respiratory acidosis. কি অবস্থায় রেসপিরেটরি অ্যাসিডোসিস হতে পারে? তোমাদের রেসপিরেটরি সিস্টেম হয়ে গেছে, হ্যাঁ হয়ে গেছে না, অনেকটা দূর হয়ে গেছে না রেসপিরেটরি সিস্টেম? হয়ে গেছে তো? তাহলে কি অবস্থায়, বুঝতে পারছো? যেমন অ্যানাস্থেটিক গ্যাস বেশি পরিমাণে আছে, শ্বাস প্রশ্বাস নিতে পারছেন, তাহলে সেক্ষেত্রে তো হতে পারে। তাহলে পরে সেখানে সেখানে অ্যালভিওলার ভেন্টিলেশন কমে গেছে। অ্যালভিওলার ভেন্টিলেশন আর মিনিট ভেন্টিলেশনের মধ্যে কি পার্থক্য আছে? কেন? হ্যাঁ, অ্যালভিওলার ভেন্টিলেশন আর মিনিট ভেন্টিলেশনের মধ্যে কি পার্থক্য আছে জানো না? মিক্সড ভেনাস ব্লাডে পার্শিয়াল প্রেশার অফ অক্সিজেন কত থাকে? মিক্সড ভেনাস ব্লাড যেটা লাংসের মধ্য দিয়ে যায়, তাতে অক্সিজেনের পার্শিয়াল প্রেশার কত থাকে? আর অ্যালভিওলির ভিতরে পার্শিয়াল প্রেশার কত থাকে অক্সিজেনের? 104। হ্যাঁ, 104। তাহলে অ্যালভিওলার ভেন্টিলেশন বলতে তোমার কি ধারণা? হ্যাঁ হ্যাঁ, ইন্সপায়ার্ড এয়ার। এই যে ইন্সপায়ার্ড এয়ার বলতে কি বোঝায়? অ্যাটমসফিয়ারিক এয়ারের সঙ্গে ইন্সপায়ার্ড এয়ারের কি পার্থক্য? আর এটা কম হবে, আমাদের যে সারাউন্ডিং যে অ্যাম্বিয়েন্ট যে এয়ার, তাতে পার্শিয়াল প্রেশার অফ অক্সিজেন বেশি আছে, আর অ্যালভিওলিতে ভিতরে সেটা তার তুলনায় কমে যাবে, বুঝতে পারিস? যেহেতু সবসময় অক্সিজেনটা সেখান থেকে বেরিয়ে চলে যাচ্ছে, ডাইনামিক ইকুইলিব্রিয়ামের ফলে সেটা হচ্ছে, সেখানে কম হবে, 104 বা 100 এরকম থাকবে, আর এটা থাকবে 150। এখন কোনো কারণে অ্যালভিওলার ভেন্টিলেশন যদি কমে যায়, তাহলে সেখানে ডেড স্পেস এয়ারটা বাদ দিয়ে নিতে হয়, তাহলে পরে অ্যালভিওলার ভেন্টিলেশন পাওয়া যায়। যদি কমে যায় তাহলে পরে সেক্ষেত্রে তোমার অ্যালভিওলার কমে গেলে পরে PCO2টা বাড়বে, PCO2 যদি বাড়ে তাহলে পরে কী হবে, সেখানে পিএইচটা কমে যাবে, এটা হচ্ছে রেসপিরেটরি অ্যাসিডোসিস। আবার যদি হাইপার ভেন্টিলেশন হয় তাহলে PCO2টা সেখানে কমে যায়, তাহলে পিএইচ ভ্যালু বাড়ে, এটা হচ্ছে রেসপিরেটরি অ্যালকালোসিস। When bicarbonate level remains constant, then initially it is uncompensated, but then compensation do take place with the help of the kidneys. Whenever there is respiratory acidosis, and within the all cells, including renal tubular epithelial cells, there is increase in the partial pressure, carbon dioxide content and partial pressure, and it is then eliminated. And so whatever bicarbonate is available, it will mop up, further increasing the bicarbonate level. In respiratory acidosis, the bicarbonate level initially is more, it will further increase when it is compensated by the kidneys, and the pH tries to return to the normal value. It is opposite in case of alkalosis, and by the pH bicarbonate diagram, this metabolic acidosis, metabolic alkalosis, and their compensation can be easily understood. pH bicarbonate diagram. In pH bicarbonate diagram, you will find, and also in the nomograms, you will find this type of graph. This is the pH in the abscissa and bicarbonate concentration. Normal value 7.4, 24 millimolar. And this type of curve can be PCO2 isobar also. And this is the blood buffer line. This is normal point. This is normal point. This is the blood buffer line. Clear? And whenever it moves into this side, it is this uncompensated respiratory acidosis. Uncompensated respiratory acidosis, and it will move in this way when there is compensation in this way. Alkalosis, uncompensated in this position, and it will be in this way by the kidney compensation. pH bicarbonate, and it is the isobar line of PCO2 40 millimeter of mercury, and it is the normal point. It is the acidosis, respiratory acidosis, respiratory alkalosis uncompensated, but it is compensated by the kidneys. So initial bicarbonate is more, and even become more when there is compensation, and it is less, and even becomes less when there is alkalosis. If the condition becomes chronic, metabolic in this way, acidosis, alkalosis in this uncompensated, it is in this way, uncompensated to compensated. 7 point. So you will read yourself. Today is the end of our discussion.
So it is the tongue, hyoid bone, thyroid cutting, one after another, side view, mandible cut section. There is a muscle, very important muscle, hyoid bone. It gives a very important task known as the lingual artery. At the level of the hyoid bone. What is it? Parts. The lingual artery is divided into third part and fourth part. How? Then to know it, you have to know the force of the artery. What is the force? খুব ভালো করে দেখো। This is the artery. It makes a loop, and these loops this loop is crossed by hypoglossal nerve and motor nerve of tongue. In the tongue mainly movement for except one muscle. All the muscles of the tongue are supplied by hypoglossal nerve. Another name is the 12th cranial nerve, 12 number nerve, cranial nerve. So last cranial nerve is the hypoglossal nerve. So this loop is crossed by the hypoglossal nerve. So it is the lingual artery, or you can identify the hypoglossal artery. Hey, hypoglossal nerve. আমরা বুঝতে পারি না জায়গাটা এত শর্ট স্পেস কোনটা hypoglossal nerve, কোনটা artery, কোনটা superior বুঝতে পারি না. Then how do you know? The lingual artery then it passes deep. So that is very important. It passes deep to the hyoglossus muscle. Then it comes out at the anterior border of the hyoglossus muscle. Then it courses up to supply the branches. So these are the usual course of lingual artery. So lingual artery has been divided into four parts. First part, from its origin to the posterior border of the hyoglossus muscle. First part. Second part, the part of the lingual artery deep to third part, the hyoglossus artery, it vertical part that ascends along the anterior border of the hyoglossus muscle, and fourth part is under surface of the tongue. So this is the four parts of the lingual artery, which supply mainly the tongue and the adjacent region, and it gives an important branch and this vertical part, also called only third part, sometimes called arteria lingua profundi. Arteria lingua profundi. So this is the lingual artery. Next important artery is the facial artery, which is often comes in the examination. Facial artery takes origin upper hyoid bone, above the origin of the lingual artery. Sometimes it may take origin along with the lingual artery, common origin. Then we call it linguofacial trunk, whatever it may be. It then courses anteriorly carotid triangle. So the first part of the facial artery is in the carotid triangle. Then এইখানটায় আমরা জানি ডাইগ্যাস্ট্রিক, আমি একটা মাসলটা সাদা দিয়ে আঁকছি, and stylohyoid muscle. This is the anterior belly. So this is the digastric triangle or submandibular triangle. So then this facial artery passing under the digastric muscle and stylohyoid muscle and entered the digastric triangle. So first part in the carotid triangle, then it passes deep to the posterior belly of digastric and entered the digastric triangle. Then it courses up. এরপরে আমি এখানে আরেকটা ছবি আঁকছি। This muscle takes origin from the mandible, is known as the, if we you clench your teeth, a muscle becomes very prominent and taut here. This is the masseter muscle. This is a very important muscle of mastication, মানে চিবানোর জন্য, chewing, This is known as the masseter muscle. আর ঠিক এইখানটায় just deep to the base of the mandible there is an salivary gland. This is the submandibular gland. And if it is a submandibular gland, the facial artery, it is the posterior border, this is the anterior border, this is the facial artery goes up along the posterior surface or posterior border of the submandibular gland and make a groove here. এখানে একটা গ্রুপ করে. So first part, so initially in the submandibular gland, it is present in the posterior surface of the submandibular gland. তারপর একটা বোঝো. This is the submandibular gland. This is the submandibular gland, right? And this is the mandible, the base of the mandible, the body of the mandible. This is mandible, and this is the lateral surface, eta, and this sponge, this is the medial surface, right? It is the lateral surface, it is your right mandible. So it is the lateral surface of the mandible, and it is the medial surface. And submandibular gland is situated like that. In the lower part, এরকম ভাবে রয়েছে এই আর তল দিয়ে in the below you can see a part of the submandibular gland, and facial artery makes first posterior surface এখান দিয়ে গেছে তো বললাম, then it hooks round the upper part and enters in between the submandibular gland and the medial surface of the mandible. এই যে ঢুকে গেছে, বুঝতে পেরেছো কি? এটা হচ্ছে তোমাদের ধরে নাও, it is the right body of the right mandible, it is the lateral or outside surface, and it is the medial surface, and my fist is the submandibular gland. Come on. And this is the facial artery. So facial artery first ascends up in the posterior border or posterior surface of the submandibular gland, then comes to the upper, then it goes between the mandible and the submandibular gland, and again আবার নিচে চলে গেল, এইখান দিয়ে উঠলো, এই গেল, আবার উপর থেকে নিচে চলে গেল। বুঝতে পেরেছো কি? এটা ক্লিয়ার? এই গেল, এই হুক করলো, এই আবার এই মিডিয়াল সারফেস দিয়ে নিচে চলে গেল, মানে অ্যাজ ইফ সাবমান্ডিবুলার গ্ল্যান্ডকে এরকম করে করলো। সো দিস পার্ট অফ দ্য facial artery lies between the submandibular gland and the medial surface of the body of the mandible. কোথায় এলো? That's important. তাহলে এখানে গেল, and comes এই জায়গাটায় এলো at the lower and anterior border of the masseter muscle. এরকম হুক করে এই জায়গাটায় এলো। Here it pierces the deep fossa and hooks round the lower border of the mandible. এরপরে সবাই ক্লেঞ্চ করো, তাহলে বুঝতে পারবে। ক্লেঞ্চ করো জোরে, এখানে টাচ করো, দপ দপ মারছে ফেসিয়াল আর্টারি। দেখো এই জায়গাটায়, তলে না, এই লোয়ার বর্ডার অফ দ্য ম্যান্ডিবল, যেখানে হুক করে এইদিকে ভেতর থেকে আবার বাইরে চলে এসেছে। এই দেখো, কেউ পেয়েছো? সবাই ক্লেঞ্চ করো, এইখানটায় টাচ করো, কেমন দেখো বুঝেছো কি? So the anesthetist when gives anesthesia to a patient, usually the anesthetist sits on the head end of the patient, মাথার কাছে বসে থাকে, আম্বু ব্যাগ এটাকে করে অথবা লক্ষ্য রাখে। So pulse, if we feel the radial pulse, you have to go cross and feel this radial pulse. It is not usually done. কি করে অ্যানেস্থেটিস্টরা? They feel only two region where they can feel the arterial pulse. One is this common carotid artery, another is here the facial artery. So this facial artery sometimes called anesthetist artery. Anesthetist artery. So anesthetists usually feel while giving anesthesia the common carotid artery here and here the facial artery. তার মানে কি রেডিয়াল আর্টারি দেখে না? দেখে, মাঝে মাঝে দেখে, মাঝে মাঝে ডরসাল স্পেডিস আর্টারি অবধি দেখে, বাট ইউজুয়ালি এখানটা দেখে। আর এইটা হাত দাও, ইজিলি ফিল করো। সো the facial artery hooking round the lower border of the mandible, and here it pierces the deep fossa. Why it pierces the deep fossa? Because all the muscles, all the face is in the superficial fossa. So it must comes in the superficial fossa. So it pierces the deep fossa and it becomes superficial. Then so এখান দিয়ে of the angle of the lips বা অ্যাঙ্গেল অফ দ্য মাউথ, এটাকে বলে অ্যাঙ্গেল অফ দ্য মাউথ। ঠিক এইখানটা আবার ফিল করতে পারো, দেখবে আবার দপদপ মারছে। 1.25 centimeter away from the angle of the mouth. Then it ascends up by the side of the এই জায়গাটায় it ends, it terminates. How it terminates? By joining with dorsal nasal branch of the ophthalmic artery. আইবলকে একটা ইম্পর্টেন্ট আর্টারি সাপ্লাই করে, their name is ophthalmic artery, which is a branch of internal carotid artery. So এই জায়গা it joining with the এটা আমরা দেখতে পাচ্ছি না, এটা ক্রেনিয়াল ক্যাভিটির মধ্যে আছে, a branch of the ophthalmic artery. So facial artery is an important communication between the internal carotid and external carotid artery, because facial artery is a branch of the external carotid artery and dorsal nasal artery is a branch of the internal carotid artery. So beginning at the superior external carotid artery, ends at the inner angle of the eye by joining with the branches of the ophthalmic artery. What are the branches? দুটো কোশ্চেন করা হবে এখান থেকে। What are the branches of the facial artery and why the facial artery is tortuous like splenic artery? দুটো কোশ্চেন করা হয় facial artery দেখে। The branches in the facial, so the facial artery has got a part which is situated in the neck, in the carotid triangle and the digastric triangle, and a part in the face. So it is called a cervical part and a facial part. Branches of the cervical part: antitetanus serum, ki ascending palatine artery, tonsillar artery, superior mental artery, and glandular branches. Ascending palatine artery is important branch. It ascends up, supply the palate, and also supply the part of the tonsil. Tonsillar branches give supply to the tonsil. And an important branch is present here, known as the superior mental artery. Plus it gives glandular branches to the submandibular gland. So these are the branches in the neck or cervical part of the facial artery. Ascending palatine artery, tonsillar artery, superior mental artery, and glandular branches. Branches in the face: superior labial artery, inferior labial artery, and lateral nasal branch. Inferior labial artery, superior labial artery, and lateral nasal branch. So these are the branches of the facial artery. Next, explain why question. Why the facial artery is tortuous? Facial artery is tortuous throughout its whole course. In the neck, in the face. In the neck, it is tortuous. A artery is usually tortuous so that it is not unduly stressed. যেখানে মুভমেন্ট হয়, যেরকম স্প্লেনিক আর্টারি, স্প্লেন মুভমেন্ট করছে, সুতরাং the splenic artery may be stretched and may be torn. To prevent it, it is tortuous. Similarly, in the cervical part, there is a movement of the pharynx, larynx, etc. so that during movement, the facial artery may be stretched and may be torn. During deglutition, during swallowing, there is a movement of the pharynx in the neck. And if the facial artery is closely applied to the pharynx, very near to the pharynx, so during movement, the facial artery may be stretched so that it gives an extra space to make it tortuous so that it is not unduly stretched. And in the face, it is tortuous due to movement of the facial muscles, also movement in the while chewing, movement of the mandible and jaw. তাহলে দুটো কারণ কিন্তু আলাদা। In the neck it is tortuous due to movement in the swallowing and deglutition, and in the face it is tortuous due to movement of the facial muscles and due to movement of the mandible during swallowing, because facial artery is very closely applied to the mandible. So mandible যেই এরকম করছে, facial artery টান পড়ে যাবে। যদি extra tortuous না থাকে, it will be torn. So this is all about the facial artery. আর বাকি আর্টারি খুব একটা ইম্পর্টেন্ট নয়, শুধু মনে রাখবে অক্সিপিটাল আর্টারি এখান দিয়ে যাচ্ছে পেছন দিয়ে in the posterior triangle up to this here, up to the posterior part of the occipital bone, and it gives two sternomastoid branch, upper sternomastoid and lower sternomastoid. শুধু একটাই লিখে রাখো, upper sternomastoid branch accompanies the accessory nerve in the posterior triangle. বাস শেষ, ছেড়ে দাও। আর ascending pharyngeal artery is the only medial branch coming from the external carotid artery, and it is usually the first branch. Or what are the terminal branches? The superficial temporal and maxillary artery is the terminal branches of the external carotid artery, right? What are the terminal branches of the external carotid artery? Superficial temporal and maxillary artery. Superficial temporal ঠিক এইখানটায় রয়েছে, and superficial temporal artery also gives a facial branch known as the transverse facial artery. Bas finished. আর বেশি কিছু পড়তে হবে না। So this is all about the anterior triangle. আচ্ছা, আমি এখন একটু জয়েন্টে চলে যাই। posterior triangleটা চলে যাচ্ছি। Craniovertebral joints. Cranio means cranium and vertebra means vertebra. কালকে যাদের ব্যাচকে বলেছি, already you know the first cervical vertebra is known as the atlas, right? This is the atlas, and atlas has got a superior articular facet which is a concave and kidney shaped. So this is the superior articular surface of the lateral mass of the atlas, right? কালকে পড়েছি আমরা। And if we turn the atlas down, this is the superior articular process and this is the inferior articular process. It is a concave and a kidney shaped oval, and it is a circular and flat. Inferior articular surface is a circular and flat. And superior articular surface and inferior articular surface in recent state, in living condition, it is covered by hyaline cartilage. It is covered by hyaline cartilage. And this is the second cervical vertebra, and the projection already you know, like a tooth-like projection, we call dens. As the Latin name of the tooth is the denta. So we call it dens or odontoid process, same meaning. So this is the dens or odontoid process. And this is the superior articular surface of the axis vertebra or the second cervical vertebra. And the axis vertebra also joins with the third cervical vertebra by this inferior articular process. So first joint we read today, atlanto-occipital joint. Atlanto-occipital, আগেই বলেছি জয়েন্টস কিভাবে পড়বো, type of joints, subtype of joints, then bones forming the joint, then the ligaments, movements, nerve supply, arterial supply, muscles producing the movements, and last but not the least, the applied part. এইভাবে আমরা পড়ি। So atlanto-occipital joint. So it is an introduction. It is a joint between this is the occipital bone. This is the outer surface or external surface. This is the internal surface. And this is called the basilar part of the occipital bone. এই পার্টটাকে আমরা বলি basilar part. এই basilar পার্টের লোয়ার সারফেসে সিমিলারলি এই অবলং শেপেড কনভেক্স আর্টিকুলার সারফেস রয়েছে, সেটাকে বলি আর্টিকুলার সারফেস প্রেজেন্ট ইন দ্য অক্সিপিটাল কন্ডাইল, কারণ এই জায়গাটাকে আমরা বলি কন্ডাইল, অক্সিপিটাল কন্ডাইল। সো দিস occipital condyle articulates with the পেছন থেকে দেখছো, this occipital condyle articles with the oblique superior articular surface of the atlas vertebra to form the atlanto-occipital joint. Why it is called atlanto-occipital joint? Because it is a joint between the atlas, atlanto and occipital bone. So it is called the atlanto-occipital joint. Type of joint, synovial. Subtype of joint, ellipsoid or condylar joint or ellipsoid joint. Bones forming the joints, superior বলে দিয়েছি, superior articular surface of the lateral mass of the atlas and articular surface of the condyle of the occipital bone. এইভাবে লিখবে, পড়েছি। What are the ligaments of the atlanto-occipital joint? Capsular ligament, সবসময় মনে রাখবে, any synovial joint, however small it may be, it is surrounded by a membrane we call capsular ligament, so that we cannot see the inside of the any synovial joint. আমরা ভেতরে কি আছে দেখতে পারি না। It is covered by a capsular ligament covering all aspects of the joint. Similarly, as it is a synovial joint, the margins of it attach the capsular ligament. Number 2, anterior atlanto-occipital membrane and posterior atlanto-occipital membrane. Though they are membrane, but they are regarded as a ligaments. So these are the ligaments of atlanto-occipital joint. কি কি তাহলে? capsular ligament, anterior atlanto-occipital membrane and posterior atlanto-occipital membrane. তোমরা এটা প্রায় দেখলাম খুব অমিট করো, anterior longitudinal ligament. All the vertebra in the anterior surface, there is a ribbon-like ligament starting from the base of the sacrum up to the occipital bone. This is known as the anterior longitudinal ligament. এটার সাথে যোগ নেই, আমি জাস্ট বলে দিলাম। এই জয়েন্টের সাথে এই লিগামেন্টের কোনো যোগ নেই, জাস্ট বললাম। এরপরে we are viewing the joint from the anterior surface. এটা কিন্তু সামনের দিক থেকে দেখছি জয়েন্টটাকে। এইটা হলো anterior longitudinal ligament and this is the capsular ligament. এই যে এইটা capsular ligament, ঠিক capsular ligament and anterior longitudinal ligament এর মাঝখানে from the superior border of the atlas to the inferior border of the or anterior border of the foramen magnum, there is a connection of membrane and this is known as the anterior atlanto-occipital membrane. Anterior atlanto-occipital membrane যার মিডলে রয়েছে anterior longitudinal ligament. So this is the anterior atlanto-occipital membrane, এই জায়গাটা। আর এইটা হচ্ছে capsular ligament of the atlanto-occipital joint. So this is the এই জায়গাটা is the anterior atlanto-occipital membrane extend from the superior border of the anterior arch of the atlas to the anterior margin of the foramen magnum. এইটা গেল anterior atlanto-occipital membrane. আর posteriorly, similarly, in the posterior aspect, there is a membrane. This is the posterior atlanto-occipital membrane extending from the superior border of the posterior arch of atlas to the posterior margin of the foramen magnum. So this is the posterior atlanto-occipital membrane and this posterior atlanto-occipital membrane kalke bolechi in the inferolateral part there is a gap so that the vertebral artery can go inside to the cranial cavity. So posterior atlanto-occipital membrane in the inferior lateral part, it is the lateral, it is the inferior. Infrolateral part, there is a gap through which, why there is a gap? The vertebral artery can go inside. এইবারে পরিষ্কার দেখতে পাচ্ছ posterior atlanto-occipital membrane. This is the posterior atlanto-occipital membrane. And there is a gap to give entrance to the vertebral artery. Nerve supply of the atlanto-occipital joint, branches of the dorsal rami. এতদিন কোথায় পড়েছি? Ventral rami. এইখানে কিন্তু dorsal rami of the C1, C2 nerve. Factors maintaining the stability, shape of the articulating surface, capsular ligaments of the joint, anterior atlanto-occipital membrane, ligaments, ligamentum nuchae, posterior muscle of the neck, especially semispinalis. এটা হচ্ছে কি বাড়াচ্ছি আমি একটু 5 নম্বর দিয়েছে, এটা 1 সেকেন্ডে শেষ হয়ে যাবে, একটু বাড়িয়ে দিলাম, বুঝতে পারলে? এইবারে যেটা ইম্পর্টেন্ট, মুভমেন্টস অফ দ্য atlanto-occipital joint. Another name of the atlanto-occipital joint is the yes joint. Yes. Another name of the atlanto-occipital joint is the yes joint. Jabe? So mainly movements in the atlanto-occipital joint is the flexion and extension and also lateral flexion. এবার জানতে হবে কি কি মাসল করে, যেটা সামনের দিকে লেগে থাকে, longus colli, rectus capitis anterior, এই যে longus colli muscle, this is the longus colli muscle. অত তোমাদের জানতে হবে না, এগুলি মাথা খারাপ করবে না। এইটা হচ্ছে ফ্লেকশন, এটা হচ্ছে এক্সটেনশন, এটা হচ্ছে ফ্লেকশন অফ দ্য নেক, এটা হচ্ছে এক্সটেনশন অফ দ্য নেক, এটা হচ্ছে ল্যাটারাল ফ্লেকশন, বুঝতে পারছো? আচ্ছা, তাহলে কে কে করছে? লঙ্গাস কোলাই, স্কেলিনি মাসল, স্ট্রানোক্লিডোমাস্টয়েড মাসল, এইগুলি করছে posterior, আর এক্সটেনশন করছে সেমিস্পাইনালিস ক্যাপিটিস, স্প্লেনিয়াস ক্যাপিটিস, অবলিকাস ক্যাপিটিস সুপিরিয়র, এইগুলি করছে এক্সটেনশন, প্লাস আপার ফাইবার্স অফ দ্য ট্র্যাপিজিয়াস। কেমন? ল্যাটারাল ফ্লেকশন করছে রেক্টাস ক্যাপিটিস ল্যাটারালিস অ্যান্ড সেমিস্পাইনালিস, এই স্প্লেনিয়াস ক্যাপিটিস অ্যান্ড সার্ভাইসিস। সুতরাং এইগুলি হচ্ছে মাসল প্রডিউসিং দ্য of the atlanto-occipital joint. তাহলে atlanto-occipital joint এক লাইনে রিপিট করছি, it is a synovial ellipsoid type of joint, right? Membrane কি, joint কি, occipital condyles with the superior articular facets of the lateral mass of the atlas vertebra. What are the ligaments? Capsular ligament, তারপরে হচ্ছে অ্যান্টিরিয়র অ্যাটলান্টো-অক্সিপিটাল মেমব্রেন, পস্টেরিয়র অ্যাটলান্টো-অক্সিপিটাল মেমব্রেন। নার্ভ সাপ্লাই, ডরসাল রামাই অফ দ্য C1 C2 নার্ভ। Movements, flexion and extension, so it is called the ES joint, and lateral flexion, it is also a part of ES. So another name of the atlanto-occipital joint is the ES joint, and muscles যেগুলি সামনে আছে সেগুলি হচ্ছে ফ্লেকশন করছে, ইনক্লুডিং স্টার্নোক্লেডোমাস্টয়েড। তাহলে আর ল্যাটারাল ফ্লেকশন করছে রেক্টাস ক্যাপিটিস ল্যাটারালি, স্প্লেনিয়াস ক্যাপিটিস, অবলিকাস ক্যাপিটিস ইনফিরিয়র, এগুলি করছে। এগুলি জাস্ট মুখস্থ করে নিতে হবে। আর নেক্সট যেটা ইম্পর্টেন্ট, যেটা একটু সময় নিয়ে পড়াবো, সেটা হচ্ছে অ্যাটলান্টো এক্সিয়াল জয়েন্ট। দ্যাটস ভেরি ইম্পর্টেন্ট জয়েন্ট, ভেরি ইম্পর্টেন্ট। অ্যাটলান্টো এক্সিয়াল জয়েন্ট, অলরেডি ইউ নো, atlanto-occipital joint is a 3 separate joints are present or 2 joints are present. কালকে বলেছিলাম, তোমাদের দিক থেকে দেখাচ্ছি, এইখানে দেখো, there is an facet present on the posterior surface of the anterior arch of the atlas. Similarly, there is a round smooth facet present in the anterior surface of the odontoid process. So when it comes here, this facet comes to contact with the facet of this to form a joint, and we call the median atlanto-axial joint. কি বলছি আমরা? Median, single, median atlanto-axial joint. Laterally, the inferior surface facet of the atlas articulates with the superior facet of the axis, one on either side, to form right atlanto-axial, lateral atlanto-axial joint, and left sided, left lateral atlanto-axial joint. So there are 3 joints, median and 2 lateral, median and 2 lateral, median single and 2 lateral. Some say the lateral atlanto-occipital joint is a 1, it has got a right component and left component, but better right lateral atlanto-occipital joint and left lateral atlanto-occipital, atlanto-axial joint. তাহলে এইটা আমরা শিখলাম কি কি জয়েন্টস and bones forming the joint হয়ে গেল। নেক্সট হচ্ছে লিগামেন্টস। ও টাইপ একটা একটা করে বলি। মিডিয়ান atlanto-axial joint, it is a pivot type of joint. আর কোথায় পিভট টাইপ দেখেছি? সুপিরিয়র রেডিও আনলার জয়েন্ট, কেমন? আর এইখানে একটা দেখতে পাচ্ছি যে মিডিয়ান অ্যাটলান্টো-অক্সিপিটাল জয়েন্ট। পিভটে কি থাকে? একটা এক্সিস রিং থাকে আর একটা রিং থাকে, এটা হচ্ছে নিয়ম। কোনো সময় রিং ঘোরে, এক্সিসটা ফিক্সড, কোনো সময় রিং ফিক্সড, এক্সিসটা ঘোরে, কেমন? এইখানে পিভট ইজ ফিক্সড, রিংটা ঘুরছে। রিংটা কে করছে? টোটাল আর এটা অ্যান্টিরিয়র মানে এই এক্সিসটা নো, রিং ইজ ফর্মড বাই এইটা হচ্ছে ওডোন্টয়েড প্রসেস। এটা হচ্ছে এক্সিস কাট সেকশন ওডোনটয়েড প্রসেস অর ডেন্স and ring is formed by this. Anteriorly, ring is formed by the anterior arch and medial surface of the lateral mass of the atlas. এই জায়গাটাকে বলে lateral mass of the atlas. So mainly it is formed by the anterior arch of the atlas, and posterior part of the ring is formed by a ligament which is known as the transverse ligament of atlas. We call it transverse ligament of the atlas. Transverse ligament of the atlas. So this is the ring. So not whole is the ring. Ring is formed by the anterior arch of the atlas, and this ligament is known as the transverse ligament of the atlas. What is the attachment of the transverse ligament? ঠিক এইখানে lateral mass of the atlas এর medial surface. It is the lateral surface. This is the medial surface. Medial surface there is a tubercle. One tubercle here and one tubercle here, and this fibrous band connects from one tubercle to the other, and so as it is transversely disposed, we call transverse ligament of the atlas. Not only that, there is another ligament. It is the transverse ligament of the atlas, and along with this transverse ligament, there is another ligament which is vertically disposed. সুতরাং টোটালটাকে আমরা বলি, as it is looks like a cross, we call it cruciform ligament. So cruciform ligament has got a horizontal or transverse part and a vertical part, and transverse part comes in formation of the pivot joint, that is the median atlanto-occipital joint. তাহলে what is the cruciate ligament? A vertical and a transverse part, two ligaments combined together to form the cruciate ligament, and this vertical part form the transverse ligament of the atlas, which forms a important ligament of the median atlanto-axial joint. Come on, this is the cruciate ligament. It has got a transverse part and a vertical part. Vertical part, a lower part attached to the axis body of the second cervical vertebra, and above it is attached to the superior surface of the basilar part of the occipital bone. And transverse part is takes from the one tubercle from the other tubercle of the axis vertebra. Axis vertebra posterior arch is cut. So this is the transverse ligament, and this is the vertical part, and two is formed the cruciform ligament. So these are the important ligament, and there are two other important ligament kalke bolte bhule gechi porate giye. One is the apical ligament of the dens and the alar ligament. Very good. Kalke bole gechi, kalke batch ke eta bolte bhule gechi. From the tip of the odontoid process to the superior surface of the basilar part of it occipital bone, a ligament is attached, and this is known as the apical ligament of the odontoid process. একটা very important কথা রয়েছে এটার ক্ষেত্রে, it is the remnant of the notochord. এই যে নোটোকর্ড ছিল তার আপার এটা হচ্ছে এইটা, it is known remnant of the notochord, and two other ligaments are present known as the alar ligament, extend from the sides of the odontoid process to the occipital bone lateral margin, and this is known as the alar ligament. So what are the ligaments present in the median type of pivot type of median atlanto-occipital joint? Number one, capsular ligament. এটা বলতেই হবে, যে কোনো সাইনোভিয়াল জয়েন্টে ক্যাপসুলার লিগামেন্ট লিখতে হবে, পরিষ্কার কথা, বুঝি না বুঝি কোথায় অ্যাটাচমেন্ট আছে কিছু জানি না, ক্যাপসুলার লিগামেন্ট লিখে দেবো। তারপরে হচ্ছে এপিক্যাল লিগামেন্ট, অ্যালার লিগামেন্ট অ্যান্ড ট্রান্সভার্স সার্ভাইকাল লিগামেন্ট। এই সার্ভাইকাল কি হচ্ছে? ট্রান্সভার্স লিগামেন্ট অফ দ্য অ্যাটলাস। ও আরেকটা লিগামেন্ট রয়েছে, সেটাও আমি বলেছিলাম, মেমব্রেনা টেক্টোরিয়া। এই পস্টেরিয়র লঞ্জিটিউডিনাল লিগামেন্ট attached to the from the sacrum to the whole of the vertebra, posterior surface of the body te lege thake. এই যে this is the posterior longitudinal ligament. একদম স্যাক্রাম থেকে এই লাম্বার থেকে শুরু হয়েছে, আপার স্যাক্রাম পেছন বডি লেগে যাচ্ছে, and when it crosses the second cervical vertebra, যেই এক্সিস ক্রস করে আছে, নেম চেঞ্জ, we call it membrana tectoria. নামটা পাল্টে গেল, আমরা এটাকেই বলছি মেমব্রেনা টেক্টোরিয়া। কি বলছি? তার মানে মেমব্রেনা টেক্টোরিয়া যদি নিচে নামে, posterior longitudinal ligament. তাহলে what are the ligaments present in this median atlanto-occipital ligament, এই joint? Capsular ligament, apical ligament, alar ligament and membrana tectoria. Lateral atlanto-axial joint, it is খুব সহজ, plain type of synovial joint, inferior articular facet of the lateral mass of the atlas and superior articular process of the axis, branches of the dorsal rami of the C1 C2 nerve. এই মুভমেন্টটা কালকে বলবো, টাইম আছে।
Electrophoresis may be defined as the migration of charged particle through a solution under the influence of an external electrical field. Frederick in 1807 was the first person who observed the electrophoresis. Okay. Any charge, a principle, any charged ion or molecule migrates when placed in an electrical field. The rate of migration depends upon the net charge, size, shape and the applied electric current. V equal to EQ by F, where V is the velocity of the molecule, E is the electric field, Q net charge on the molecule, F is the frictional coefficient which depends upon mass and shape of the molecule. The rate of migration of an ion in an electrical field depends on net charge of the molecule, size, mass, shape of the particle, strength of the electrical field, properties of supporting medium and the temperature of operation. The factors affecting the electrophoresis: sample, charge, rate of migration increases with increase in the net charge, size, rate of migration decreases for larger molecules and it is due to the ionic strength, rate of migration increases in high ionic strength, pH, ionization of the organic acid increases as pH increase, supporting medium, adsorption reduces both rate of migration and resolution of separation of molecules. Electroendosmosis, it is due to the presence of charged groups on the surface of the supporting medium. For example, paper. For paper it is carboxyl group, agarose it is sulfate group and it will accelerate the movement of cations but retard the anion movement. Basic types: anaphoresis and cataphoresis. Anaphoresis means electrophoresis of negatively charged particle or anions. Cataphoresis means electrophoresis of positively charged ions or cations. Now, these are the types of electrophoresis. Zone electrophoresis and moving boundary or frontal electrophoresis. Zone electrophoresis again can be divided into paper electrophoresis, gel electrophoresis, thin layer electrophoresis and cellulose acetate electrophoresis. Moving boundary or frontal electrophoresis, it may be capillary electrophoresis, isotachophoresis, isoelectric focusing and immunoelectrophoresis. General apparatus, it consists basically of the power pack, electrophoresis unit which contains the electrodes, buffer reservoir, support for electrolysis medium and a transparent insulating cover and sample injector and detector. It is the electrophoretic chamber, this one, and here both are the electrodes. It is connected to a power supply and here we keep the buffer solution. This is the buffer reservoir, okay, and we put, it is for paper electrophoresis. Here we put a chromatography paper or filter paper, and both the end of the paper dipped into the buffer solution. Okay, and here we apply the sample injector through, and by the detector we can detect. It is a picture of capillary electrophoresis. Capillary tube is used, and whole other system বাকি সব কিছুই কিন্তু একই, others are same, anode, cathode. Okay, here the sample, power supply, and we detect here. Okay, it is the lead, we cover it. General method of operation: saturation of the medium with the buffer. Okay, this chamber is filled with the buffer. Okay, sample application: it is a gel electrophoresis. It is the gel. Here we prepare the gel, and through this comb, when the gel is in liquid form, we just place the comb, and after when the gel solidified, we just remove it and forms the wells for sample application. Okay, sample application, electrophoresis separation and detection. Process is the same procedure. Here is the power supply. These are the electrodes, one positive and the one negative electrode, and here time is 0 when the application is done. It is the agarose gel electrophoresis. DNA sample loading here, and after 30 to 45 minutes we see the separation. DNA separates. Migration is different for different samples, and here is the marker DNA, and we compare it and detect it by UV transillumination, and documentation is done. Zone electrophoresis, it involves the migration of the charged particle on the supporting medium. Paper, cellulose acetate membrane, starch, gel, polyacrylamide are used. Components separated are distributed into discrete zone on the support media. Supporting medium is saturated with buffer solution. Small volume of sample is applied as narrow band. On application of the potential difference at the end of the strip, components migrates at a rate determined by the electrophoretic mobility. The components which are determined, they move or migrates at a rate determined by its electrophoretic mobility. Advantage: it is useful in biochemical investigations, cost is low, small quantity of the sample can be analyzed, and easy maintenance. Disadvantage: unsuitable for accurate mobility and isoelectric point determination. Due to the presence of supporting medium, technical complications such as capillary flow, electroosmosis, adsorption, and the molecular sieving are introduced. This means, as we use the supporting medium buffer system, so the buffer, which itself has ions, and it is the electrical current when passed, they also move according to their mobility and character. So this will interfere with the separation process. Now this is the paper electrophoresis. It is the basic form. Okay, it is the form of electrophoresis that is carried out on filter paper, and this technique is useful for separation of small charged molecules such as amino acid and small proteins. These are the anode chamber, cathode chamber. Here the buffer solution is kept. This is the filter paper. Okay, and when it is supplied by the power supply is there, and we apply the sample in spot form or narrow stick, and when the power supply is given, it will migrate, and after few times, 30 to 45 minutes, the components will migrate at a different rate according to their properties, and we found these are the bands. Filter paper, it is the stabilizing medium. Whatman filter paper, cellulose acetate filter paper, or chromatographic paper can be used. apparatus, power bank, electrophoretic cell that contains electrodes, buffer reservoir, support of paper, transparent insulating cover. Sample application, the sample may be applied as a spot or as a uniform streak. Electrophoretic run, the current is switched on after the sample has been applied to the paper and the paper has been equilibrated with the buffer. And the types of buffer used depend upon the type of separation. Once removed, the paper is dried in vacuum oven. Detection and quantitative assay. To identify unknown components in the reservoir mixture, the electrophotogram may be compared with another electrophotogram on which the standard components have been electrophoresed under identical conditions. This means in this previous picture we saw that the electrogram of the standard and we compare it electrogram of the standard, which is the marker DNA here, and we compare this with the standard to identify unknown components in the result mixture. The electrophotogram may be compared with another electrophotogram on which the standard components have been electrophoresed under identical condition. Condition is, will be same, and we will compare the interested component with the standard component, and thus we separate and identify them. Physical properties like fluorescence, UV absorption and radioactivity are exploited for detection. In the sample is applied as a circular spot on a strip of Whatman filter paper moistened with the buffer solution. The end of the paper are immersed in separate reservoirs containing the buffer and in which the electrodes are fitted. Upon passing electrical current, the ions in the sample migrate towards oppositely charged electrodes, and this method is suitable for low molecular weight compounds such as amino acid and nucleotides. Okay. The cathode, we all know that the cathode is the negatively charged and anode positively charged. So ion will move in the oppositely charged electrodes, means the positive charged anions will go towards the cathode and the cations will move towards the anode. It is the paper electrogram, and it is the anode side and this is the cathode side. Here it is the sample of application origin side, and albumin carries the most negatively charged, so it is go towards the anode. And here is the alpha 1, it is the serum electrophoresis of protein. Albumin is most towards the anode, then alpha 1, alpha 2, beta 1, beta 2 and the gamma. Gamma is close to the original site of origin, and here is the negative site, cathode. Gel electrophoresis. It is the technique used for separation of DNA, RNA or protein molecules according to their size and electrical charge using an electric current applied to the gel matrix. Gel is a cross-linked polymer whose composition and porosity is chosen based on the specific weight and porosity of the target molecules. Types of gel: agarose gel, polyacrylamide gel and Cefadex gel. In case of gel electrophoresis, the basic concept is similar. Here is the power supply, positive anode and cathode is their electrode, and this is the gel. Gel is formed, gel casting is done, and it is placed and comb is inserted and forms the oils, and the electrolyte solution is there and the sample application in the wells, and then power supply is given, and after few minutes, 40 to 45 minutes, there is separation of the components according to their electrical property and the size. The first step is the preparation of the sample. Here it shows the DNA separation. In case of DNA, we prepare the solution by adding blue dye, so it is easy to identify. When we apply the sample, it is a blue color and it shows easily. And Isolate the DNA and prepare the solution by adding blue dye so that it will be easy to observe the movement of the sample taking place in the gel. Preparation of agarose, TAE, T for tris, A for acetate and E for EDTA. It is a buffer solution, helps to generate an electrical field during the process of electrophoresis. To prepare the solution, for example, if there is a requirement of 1% agarose gel, then add 100 ml of TAE to 1 gram of agarose. Agarose is a powder form, okay, and if we take 1 gram of agarose and mixed it with 100 ml of TAE buffer solution, then prepare the gel. The higher percentage of agarose will give a denser screen and dissolve the agarose by heating the agarose TAE solution and form the liquid gel, and then gel casting. Pour the agarose TAE solution in a casting tray. Allow it is a square shaped tray, and allow it to cool and solidify, and a gel slab along with the wells is ready. And during the liquid state, we apply the comb and just solidify the gel and remove the comb. So this area will forms the wells. And now fill a chamber with TAE buffer. Here also the electrophoresis chamber is filled with the buffer solution. Here the buffer is TAE buffer, and place the solid gel in the chamber and place the gel in such a position that it is near the negative charge electrode. Gel loading loads the wells with DNA sample and DNA ladder. DNA ladder is the reference for sizes. Reference DNA. Process of electrophoresis: connect the positive and the negative points to power supply and chamber, and switch on the power and migration in the DNA sample due to the electric field generated, and the negatively charged sample will move towards the positive point and away from the negative electrode. The basic principle is same for all kind of electrophoresis. That means the negatively charged will move towards positively charged electrode, and the positively charged sample will move towards the negatively charged electrode. As DNA is negatively charged, so it is moved towards the positively charged electrode. Okay, and observe the DNA. Once you see the migration of the blue colored, as we put the blue dye in the DNA sample, so we see the blue color will migrate. Okay, and once you see the migration of the blue colored DNA sample in the gel, switch off the power supply and remove the gel and place it in the ethidium bromide solution. Ethidium bromide solution is the staining solution. It is specific for DNA identification. There are other type of staining method for other components. And expose the ethidium bromide stained gel under UV light and take a picture. DNA bands appear in the lane of the respective wells. Also, the DNA ladder is visible, and therefore the length of DNA bands can be determined. Below is the image of experiment. Okay, and this is the same power supply and the gel casting, sample of wells, an electrolyte solution. It is the positive end, it is the negative end. Here the sample of application. The buffer solution for proteins, buffer will be barbitol and phosphate. For nucleoproteins, buffer will be acetate buffer and citrate. For amino acid, it will be phosphate buffer and Michaelis. Staining for proteins, bromophenol blue in acetic acid. Nucleic acid, it is the ethidium bromide. For polysaccharides, the staining will be iodine staining, and the glycoproteins, it is Alcian blue. Now, agarose gel electrophoresis, the basic principle is same. Here is the agarose gel casting is done. A highly purified uncharged polysaccharide derived from agar, used to separate macromolecules such as the nucleic acid, larger proteins and protein complexes. It is prepared by dissolving 0.5% agarose in boiling water and allowed to cool it at 40 degrees centigrade. Okay, 0.5% agarose dissolved in boiling water and allowed to cool 40%, and then the gel is formed. It is fragile because of the formation of weak hydrogen bond and hydrophobic bonds. It is again the picture showing the agarose gel electrophoresis. Mixed agarose with buffer and boil the mixture in microwave, cool it at 65 degrees centigrade, and then comb is inserted and form the oils. Then gel solidification at room temperature and comb is removed and the oil remains. And after that, the DNA sample of interest, and it is sample is loaded into the wells, and the separation of the fragments by electrophoresis, and it is the DNA ladder portion, and we compare it after separation and measure the length, and it is plotted and detected by UV light or fluorescence or dye using. Okay. This is the SDS page electrophoresis. SDS means the sodium dodecyl sulfate polyacrylamide gel electrophoresis. It is an anionic detergent which binds strongly to and denature the protein. We denature the protein, and then protein SDS complex carries net negative charge and hence move towards anode, and the separation is based on the size of the particle and also be used for determining the relative molecular mass of the protein. Here SDS has a property, detergent property, so it denatures the protein and then it forms a net negative charge in all the protein compounds. So the charge is balanced, in charge is same for all the compounds. Then next, the protein will be separated on their basis of size. Electrical charge is negatively charged. All the protein compounds are negatively charged due to this SDS after forming the protein SDS complex, which carries negative charge. And now they move towards anode, and separation is based on size of the particle. Okay, and it is determine the relative molecular mass. Application useful for protein purification, determining the molecular weight of the protein, quantifying proteins, and blotting applications. Process of SDS page. Boil the sample for 10 minutes to completely denature the proteins. Assembly the gel into the apparatus. Here this blue color is the gel, and there are two slides. Between these two slides the gel is placed. Okay, there is a screw system which keep it in place, and then the next all is the same. Okay, assembly the gel into apparatus, pour the buffer solution into the chamber, load 20 microliter of the sample into the wells. After that, run electrophoresis by connecting the current supply and visualize the band under UV light or staining technique. Okay, after few times, 45 minutes, this will run. This is the application site, and this will run anode, and there will be the different position according to their size. Thin layer electrophoresis. Electrophoresis studies can be carried out in thin layer of silica or Kieselguhr alumina. Kieselguhr is a complex of silica which has a insulated type of activity. Advantage of this: less time consuming and good resolution. Application used in combined electrophoretic chromatography studies, in two-dimensional studies of protein and nucleic acid hydrolysates. Means when electrophoresis and chromatography are mixed and two-dimensional study of protein and nucleic acid are done, then thin layer of electrophoresis is used. Cellulose acetate electrophoresis, it contains 2 to 3 acetyl groups per glucose unit, and its absorption capacity is less than that of the paper. It gives sharper band, provides a good background for staining glycoprotein. Advantage: no tearing of protein, and gives sharp band and good resolution. Disadvantage: expensive, presence of carboxylic residue causes induced electroosmosis during the process. Cellulose acetate electrophoresis is used in case of hemoglobin electrophoresis. In an alkaline pH, hemoglobin is negatively charged and the molecules will migrate towards the anode, and the various hemoglobin moves at different rates depending upon their net charge, net negative charge, and which in turn is controlled by the composition of the hemoglobin molecule. The process is same. Here the cellulose acetate is used, and it is used mainly for hemoglobin electrophoresis. Okay, this is a picture of showing the hemoglobin electrophoresis. This is the site of origin where the samples are put, and after few time it shows the bands. The bands are separated. It is the A, F component, S, C, A2. In case of normal person, this is the pattern of band. In case of sickle cell trait, there will be HbA2 band, S band, like F band and A band. In case of sickle cell disease, the S band will be more prominent. In case of sickle C, there will be a C band, one S band and one A2 band. In case of C trait, there will be all type of except the S band. Thalassemia major, there will be fetal hemoglobin is more, so the F band is more. Thalassemia minor, there will be little bit of F band and A band and A2 band. And in case of sickle cell with thalassemia, there will be S band, F band, A band and A2 band. Okay, by these bands we can understand what kind of hemoglobinopathy is there. It is another picture showing the sickle cell anemia and sickle cell trait and normal hemoglobin electrophoresis. In case of, this is the site of origin. In case of normal person, there is only A variant. In case of sickle cell anemia, there will be only S band, and in case of trait, sickle cell trait, there is S and HbA. So two bands are there. In one is at position of S and one is at position of A band. Okay. This is another picture, beta thalassemia patients. Here in case of beta thalassemia patient, hemoglobin F band is more and little bit of HbA. In case of normal pattern, HbA is more, fetal hemoglobin is very much low, and A2 is also low. Another, this one is the serum electrophoresis of protein. This is the cathode, this is anode. Albumin is mostly negative, so it comes towards more to anode, and then alpha 1, alpha 2, beta 1, beta 2 and gamma. And gamma is more close towards the site of origin. This picture showing the alpha 1 absence. There is no alpha 1 band. Okay. Another again picture, one picture of serum protein electrophoresis showing the albumin. This is the normal pattern. Okay. Albumin, alpha 1, alpha 2, beta 1, beta and gamma. In case of multiple myeloma patient, there is gamma band is more. Okay. So if we analyze the serum protein of a multiple myeloma patient, we can found this kind of pattern, and from this we can say yes, these patients are multiple myeloma because of the gamma band is high. Usually it is this type. It shows the normal percentage reference range of protein. Total protein is 6 to 8 gram per dl. Albumin is 3.5 to 5. Alpha 1 globulin 0.1 to 0.4. Alpha 2 0.4 to 1.3. Beta globulin is 0.6 to 1.3 gram per dl, and gamma globulin is 0.6 to 1.5. This is the normal pattern. Again, this one shows the normal pattern. Albumin is high, alpha 1, alpha 2, beta, gamma. In case of acute inflammatory patient, this will be the pattern. You can take a picture of that. Okay. And this is the alpha 1 antitrypsin deficiency. Alpha 1 is less. Okay. This is the liver cirrhosis patient pattern. This is the multiple myeloma patient's serum electrophoresis pattern, and this is the nephrotic syndrome pattern. The multiple myeloma is very much common, and it can be asked in examination also. What kind of band you will find in serum electrophoresis of a multiple myeloma patient, and what is the normal pattern. Now, the next type of electrophoresis, which is the moving boundary electrophoresis. Here principle, the moving boundary method allows charged species to migrate in a free moving solution without the supporting medium. Advantage, biologically active fractions can be recovered without the use of denaturing agent, and minute concentration of the sample can be detected. Disadvantage, it is costlier and elaborate optical system are required. Application, to study the homogeneity of a macromolecular system. Analysis of complex biological mixture. Now, moving boundary, the name suggests the boundary is moving. It is a U-shaped glass cell of rectangular cross section with electrodes pressing in each one limb of the cell. The two electrodes are placed here, and this portion contains the buffer solution, and the sample of mixture is given here, and after applying the current, these will migrate according to their properties. Sample solution is introduced at the bottom or through the side arm, and the apparatus is placed in a constant temperature path at 40 degrees centigrade. Detection is done by measuring the refractive index throughout the solution. That means here detection is done by the refractive index throughout the solution. Okay. Now, capillary electrophoresis. Again, the principle is same. Here, the difference is here capillary is used. Capillary tube is placed between the two buffer reservoir, and the electric field is applied. The separation depends on electrophoretic mobility and the electroosmosis. Defined volume of analyte is introduced into the capillary by replacing one buffer reservoir with sample vial. Electrophoretic separation is measured by detector. Using narrow bore tube, capillary electrophoresis remove the Joule heating effect, which decreases band broadening and giving faster separation than gel. Capillary electrophoresis uses tubes of 20 to 100 micrometer diameter and 20 to 100 centimeter length. The CE is used with or without gel, and longitudinal diffusion is the main source of band broadening. Electroosmosis. What is electroosmosis? It is the movement of liquid in a porous material due to an applied electrical field. Okay. Movement of liquid in a porous material due to the applied electrical field means osmosis due to the effect of electrical field. Here, in case of capillary electrophoresis, the separation depends on electrophoretic mobility and this electrical osmosis. Just see this, all the process is same. Only difference is here is the capillary tube is used for electrophoresis. Others all are same. Isotachophoresis, you can get a short note of that in exam. Iso means equal, tacho means speed, and phoresis means the migration. The technique of isotachophoresis depends on the development of potential gradient. Used for separation of small ionic substances, they migrate adjacent with contact one another but not overlapping. The sample is not mixed with buffer prior to run, and hence current flow is carried entirely by the sample ions. Due to as this is not mixed with buffer, so the current is only flow by the sample ions only. Okay. Iso means equal and the tacho means speed. Equal speed electrophoresis. Application, separation of the small anions and cations. Isoelectric focusing. Isoelectric focusing, also known as the electrofocusing, is a technique for separating the different molecules by difference in their isoelectric point. What is isoelectric point? It is the pH at which the compound is neutral. That means there is no negative charge, no positive charge. So isoelectric focusing means it is on the basis of the isoelectric point. Technique of separating different molecules by difference in their isoelectric point. Every molecule has different isoelectric point at which point of pH the molecule have no net charge. So it is suitable for separation of amphoteric substances. Amphoteric means again which is neutral. It is a type usually performed for protein in gel, and that takes advantage of the fact that overall charge on the molecule of interest is a function of the pH of the surrounding. Method is high resolution because it is depends on the isoelectric point, which is very much precise for each molecule. So it is there is high resolution. Application: human genetic lab, useful for separating the isoenzymes, and research in enzymology and immunology. Isoelectric point is the pH at which the molecule carries no net electric charge or is electrically neutral. Okay. Now the next is immunoelectrophoresis. The name suggests immuno means antigen antibody reaction. Here the electric field is applied to the study of antigen antibody reactions. It is called immunoelectrophoresis. The antibody are electrophoretically separated and antigen diffuses towards each other, resulting in precipitin arcs where antigen antibody complexes forms. It is used to detect the presence of antibodies, used mainly to determine the blood level of three major immunoglobulins IgM, IgG, IgA. Here antigen antibody reaction are done, and when antigen is mixed to their specific antibody forms a precipitin arc, and this is interpreted. Okay. Antigen molecules are separated according to the difference in their electrical charge by electrophoresis, and antibody is placed in a trough cut in the agar. Antibody diffuses towards the antigen. Antibody diffuses towards the antigen and forms the precipitin arc. And interpretation: precipitin arc represents the individual antigen. Because antigen antibody reaction is very much specific, antibody will bind only to its own antigen, and this will form a precipitin arc, and this is identified, and it is used in immunoelectrophoresis. Now the application of electrophoresis: DNA sequencing, medical research, protein research, purification, agricultural testing, separation of organic acid, alkaloids, carbohydrates, amino acids, alcohols, phenols, nucleic acid, insulin, in food industry. It is employed in biochemical and clinical field, in the study of protein mixtures such as blood, serum, hemoglobin, and in the study of antigen antibody interactions. Electrophoresis in combination with autoradiography is used to study the binding of iron to serum proteins. Used to analyze the steroid and antibiotics, for testing the purity of thyroid hormones by zone electrophoresis. Paper chromato and electrophoresis is used to separate the free insulin from plasma proteins. It is used for diagnosis of various diseases of kidney, liver, and CVS, cardiovascular system. It is also used for separation of scopolamine, ephedrine using the buffer at pH 4.2. It is also used for separation of carbohydrate and vitamins, and quantitatively separation of all the fractions of cellular entities. Antibiotics, RBC, enzymes also are possible by electrophoresis. Okay.
Edema where you will get on the feet. Okay, so why the face is important? You have to see periorbital edema. কোথায় edema পাবি? Just circular to the eye. ঠিক আছে? If you notice any patient is having edema, check for the renal function, check for the lung function. This thing you have to know. Okay. আচ্ছা আর কি বলছে? Why the facial muscle? Why there is a gap? What I said, if anything injury to the face, why there is a permanent mark? Why? Because the facial muscles are lying on a very dense elastic tissue. Okay, it is lying on the very dense elastic tissue. So that's why there is no healing. Okay, there is a permanent mark over there. So next one is superficial fascia. What are the contents of the superficial fascia? Number one is facial muscles. Okay, second one is vessels and nerve, and the third one is the fat. Okay, So deep fossa is absent in the face. Okay, this thing already we have discussed. It is only present on the parotid gland and also the buccinator muscle. So where you have written the parotidomasseteric fossa, so just write it down. It is extend from the parotid gland to the masseter and even to the buccinator, because buccinator is also considered as a accessory muscles of mastications. Okay. Okay. So tell me embryologically how the face is developed, or the facial muscle and the facial nerve. So it will develop from second branchial arch. Right? So second branchial arch er kon nerve, which is a nerve? Second branchial, there are some 4 pharyngeal arch, no? There are muscles and also the occipital dermatome. It will develop from that particular branch. Okay. This is known as pharyngeal arch. ঠিক আছে, তো ফার্স্ট pharyngeal arch এর কোন কোন মাসল হবে অলরেডি I have discussed in anterior triangle. So all the muscle, write it down. Muscle of first pharyngeal arch. Tell me at first the nerve, কোন নার্ভটা সাপ্লাই করবে ফার্স্ট pharyngeal arch? Mandibular division of trigeminal nerve. So write it down. The first branchial arch এর nerve হচ্ছে mandibular division of trigeminal nerve. Okay, and which are the muscle it would be supplied? Kiki muscle thale supply korbe? All the muscle of mastication. Okay, and additionally which are the other muscle, other 4 muscle? Total 8টা muscle kin buccinator asbe na, because buccinator is supplied by facial nerve. Second arch er hoye gelo. Eta একটা চার্ট আছে। Okay, IB Singh এ দেখবি pharyngeal arch খুলবি, you will get one chart. Okay, so please follow that one. ঠিক আছে, তাহলে ফার্স্ট আছে আর 4টি মাসল কি কি হবে? মাসল অফ মাস্টিকেশন ছাড়া, রাইট ইট ডাউন। anterior belly of digastric, anterior belly of digastric, এটা একবার বলেছিলাম তো, anterior belly of digastric, mylohyoid, tensor tympani or tensor valley palatini. Now coming to the muscle of second branchial arch. So which is the nerve for second branchial arch? It is the facial nerve or the 7th cranial nerve. The nerve for the second branchial arch, this is the 7th nerve, that is also known as facial nerve. Okay. So facial nerve kake kake supply korbe? All the muscle of face, right? Rather than আর কাকে কাকে সাপ্লাই করবে? Write it down. There are additional 2 muscle. Posterior belly of digastric, আরেকটা হচ্ছে stylohyoid. মনে থাকবে আরেকটা হচ্ছে stylohyoid. So these are supplied by the nerve for the second branchial arch. Okay, now if you see the whole musculature of face, it is divided into 6 groups. Okay, so first one is the muscle of scalp. So tell me which is the muscle? Occipitofrontalis. Okay, so muscle of scalp, consider only one muscle, that is occipitofrontalis. তারপরে কি আছে? Muscle of the eyelids. Okay, so eyelids, for eye we have got how many muscle? Which are they? সবার আগে see the we have seen in the frontal bone the eyebrow are situated in the superciliary arch. তো সেখানে কি মাসল পাবো? corrugator supercilii. Okay, corrugator supercilii. Then আর কি কি পাবো বল orbital group এ? Orbicularis oculi, very much important, may comes as long question also, may comes as short note also. Okay, buccinator and orbicularis oculi you have to study separately. বুঝা গেল? So orbicularis oculi, next one is LPS, that is levator palpebrae superioris. ঠিক আছে, so these are the muscle of the eyeball. So next one is muscle of auricle. So this thing I have discussed, কি কি muscle আছে? 3টে muscle আছে. One is auricularis superior, auricularis anterior, auricularis posterior. So what is peculiarity of this muscle? It is a vestigial muscle. Okay, because you will get the other mammals could able to move the ear, but the humans could not. Okay, so it is a vestigial muscle. These 3 muscles are vestigial muscle. Okay, then next one is muscle of nose. Okay, so how many muscle in the nose? 4 muscles are there. Write it down. First one is procerus. Procerus kothay thake? At the root of nose. Okay, procerus kothay thake? At the root of nose. Okay, then next one is procerus chhara ar ki pabe? Compressor nasi, dilator nasi. Write it down. Compressor ekta nose take compress korche, ekta nose take dilate korche. Okay, compressor nasi, dilator nasi. Okay, arekta important muscle hoche jeta which is present on the nasal septum. So that is known as depressor septi. Depressor septi. Okay, so these 4 are the muscle in the nose. Okay, then muscle around the mouth. So many muscles are there. Okay, so tell me some. First muscle which is covering the oral cavity, that is orbicularis oris. Okay, ar ki muscle pabe? Levator labii superioris. Levator labii superioris. Arekta ki pabe? Levator labii superioris alkinesi. Okay, has got 5 components. Most longest muscle. Okay, longest in the term of sentence. Okay, so this is both are present on the upper surface of the lip. Okay, lower lip e ki pabe? Depressor angularis oris, jeta angle ke depress kore. Okay, arekta ki pabe? Depressor labii inferioris. ঠিক আছে, depressor labii inferioris. আর একটা blowing muscle which is present on both sides, that is the buccinator. Okay, buccinator. And another muscle over here is rhizorius. Rhizorius, and on the chin we have got mentalis. Okay, so these are the muscle. Okay, so we will discuss one by one. Last one is, tell me which is the muscle of neck? Only one muscle, not sternocleidomastoid. So it is extend from the lower surface of face to the neck. So that is the platysma. So it is one of the example of subcutaneous muscle. Okay, it is one of the, write it down, it is one of the example of subcutaneous muscle. Platysma. Okay. Okay, so see this thing. Then what are the muscle you could get over here? What is this? First one is, this is the frontalis. So frontal belly of occipitalis. Then what is this? I told you procerus. Ekhane ki ache? Superciliary arch, corrugator supercilii. So tell me the function of muscle. Frontalis er ki function hobe bol? So what is, tell me the facial expression it will produce. Huh? So it is causing the horizontal crease over the forehead. Okay, ki korche? The frontal belly of occipital frontalis. Then next one is corrugator supercilii. What it is doing? All the movements of the eyebrows. Okay, superciliary arch eta ache. Tarpore next deck, what is this muscle? Procerus. So procerus ki korche? The small vertical crease on the root of nose, it is produced by procerus. ঠিক আছে, আর by eye, what is this? You could see for eye, what are the thing you could get? That is orbicularis oris, and another one is orbicularis oculi. Okay, and what is the function of levator palpebris superioris? So there are 2 type of closing of eyelid. Okay, which is just lightly closing or closing of eyelid, that would be produced by levator palpebris superioris. But when you are constricting the eyeball with force, that would be produced by orbicularis oculi. Bujha gelo? So these are the 2 parts. So what are the muscle other than that? You are having zygomaticus major and zygomaticus minor, where it is present on the zygomatic arch. Okay, so superiorly there is other muscle that is known as masseter. Masseter don't consider as a facial muscle. Mastication. Okay, then buccinator has got dual function for mastication as well as for the expression. Okay, so now write it down about, etao kintu long question e aste pare ba short note e aste pare, that is occipitofrontalis. Occipitofrontalis, some muscle you have to study in details. Okay, so it has got 2 belly, one is occipital belly, another one is frontal belly. Okay, so occipital belly kothay hobe? Lateral 2/3 of highest nuchal line. So you have know now highest nuchal line kothay thake? Occipital bone. So there you will get insertion kothay? Gallia aponeurotica. So tell me something about Gallia aponeurotica. It is just a aponeurosis. Okay, it is just the aponeurosis. Okay, nerve supply টা important কিন্তু দেখ দুটো nerve supply আলাদা. Okay, so write down occipital belly is supplied by এখানে যে লোকেশনে যে নার্ভটা আছে সেটাই সাপ্লাই করবে, সেটা কি posterior auricular branch of facial nerve, posterior auricular branch of facial nerve. Okay, so frontal belly we are having the origin is gallia aponeurotica, just opposite. Origin টা কোথায় হচ্ছে gallia aponeurotica, insertion কোথায় হবে the fossa and skin overlying the frontal bone. Okay, and nerve supply is the temporal branch of facial nerve. Now tell me how many branches the facial nerve has got. Facial nerve টা কোথা থেকে আসছে বলেছিলাম এর আগের দিন, stylomastoid foramen. Okay, along with the stylomastoid artery. কোথায় আছে stylomastoid foramen টা? Between the styloid process and the mastoid process. Facial nerve টা বেরোলো, বেরিয়ে parotid fossa তে pierce করছে. Okay, so there are 5 nerve. How you remember? First one is the temporal, then second one is the zygomatic, third one is the buccal, fourth one is the marginal mandibular, and the last one is the cervical. Okay, so there are 5 nerve. Okay, so this is the temporal branch of facial nerve. So see, this is the muscle that is known as occipitofrontalis. Okay, and where does it insert? Gallia aponeurotica. Okay, so you have to remember about the nerve supply. ঠিক আছে, occipital belly is supplied by কি পড়লাম এত posterior auricular branch of facial nerve. Okay, so see, these are the function that has been done by the occipitofrontalis. So all the horizontal creases that would be produced by different type of action. Okay, when you are very much surprised, at that time also you are having these muscle actions. Okay, so next one is the orbital group. So orbital group, or first one is the orbicularis oculi. First one is the orbicularis oculi, then corrugator supercilii, levator palpebrae superioris. Okay, among them which is supplied by oculomotor nerve? Write it down. Which is supplied by oculomotor nerve? That is levator palpebrae superioris. Have you know one disorder that is known as ptosis? Ptosis পড়েছিস? কিসে পড়েছিস বলতো? হর্নার সিনড্রোম, তাই না? হর্নার সিনড্রোমে পড়ে সুপিরিয়র ভেনা কাভার ওখানে যেটা হয়. So why it is produced? So there will be involuntary drooping of eyelid. Drooping of eyelid. So this is also known as ptosis. Ptosis will start from P. Okay, ptosis. So ptosis কেন হয়? Because of involvement of LPS. কোন মাসেল ইনভলভ হয়? LPS. Okay, হ্যাঁ, Horner syndrome, oculomotor. So how many eyeballs muscle are supplied by oculomotor nerve? Except the superior oblique, and another one is lateral rectus. Superior oblique would be supplied by trochlear nerve, lateral rectus would be supplied by abducens nerve. So remaining all eyeball muscle including the LPS would be supplied by oculomotor nerve. Okay, so next one is, this is very much important for short note. Okay, orbicularis oculi. দেখ এর দুটো পার্ট আছে. orbicularis oculi has got 2 part. One is orbital part and another one is palpebral part. Okay, so if you see the orbital part, it will have origin from medial palpebral ligament. Medial palpebral ligament কোন দিকে আছে? Medially আছে. Okay, and insertion কোথায় হবে? It has got no lateral attachment. This is the peculiarity of orbital part of orbicularis oculi. Why? Because it is forming one loop. Medial palpebral ligament টা হচ্ছে root. Okay, প্রতিটা মাসল একটার পর লুপ তৈরি করছে. Okay, so that is the orbital part of orbicularis oculi. Then what about the palpebral part? Palpebral, see, this is also when you forcefully close your eye, so that would be action would be done by orbicularis oculi. Okay, then palpebral part. So palpebral part origin is medial palpebral ligament, insertion in the lateral palpebral raphe and skin of the eyelids. Okay, so action would be, what are the action? So when you are sleeping, it is gently closes the eye and also dilates the lacrimal sac. Okay, so what is the function? Lacrimal sac টা কোথায় থাকে জানিস? Lacrimal sac টা কোথায় থাকে? Lacrimal gland টা কোথায় থাকে? Lacrimal sac টা কর্নারে থাকে, medially sac টা. Okay, so that is forming the lacrimal apparatus. Okay, lacrimal gland টা কোথায় থাকে? Laterally. Okay, lateral side. So ওখান থেকে tears would be secreted coming to the lacrimal sac. And sometime you know when you are taking any spicy spicy food, it is also some fluid is coming from the nose. Why? Because of the common connection nasolacrimal duct. বোঝা গেল? Common connection. So see, this is the how nicely it is attached to the medial palpebral ligament. প্রতিটা এখানে লুপ তৈরি করছে, except what is this? এই যে পার্টটা দেখতে পাচ্ছিস, this is the, so you are discussing about what? About spicy food. So see over here, this is the palpebral part, okay, and this is the orbital part, okay. So this is all about the orbicularis oculi. And if you see, this is what? This is the zygomatic arch. ভালো করে দেখ. See everyone, zygomatic arch. So you will find zygomaticus major on the superior aspect, zygomaticus minor in the inferior aspect. Okay. So see, this is the medial palpebral ligament. So this is the palpebral part and this is the orbital part. Okay. So what about the lateral palpebral ligament? Which part is attached? Lateral palpebral ligament ke attached hoy? That is the palpebral part of orbicularis oculi. ঠিক আছে? Lead? Dictigatic membrane. Oh, this one is the medial palpebral. এইটা বলছিস? This one. This is the part of eye. This is the part of eyeball. Vestigial. That is also vestigial organ. Okay. Okay. So now what are the action? So closing of eye forcefully. So that is orbicularis oculi. Okay. So this is the main function. Now coming to corrugator supercilii. So corrugator supercilii are present on the superciliary arch and insertion on the skin of eyebrows. So what it will produce? It will produce the wrinkles. Okay. Wrinkles on the forehead and also the frowning movement. Okay. Frowning expression. Now write it down, very much important, LPS. LPS. So that is levator palpebrae superioris. Okay. Origin is from lesser wing of sphenoid. What I told, which one would be superior? Lesser wing would be superior. আর দুটো মিলে কি তৈরি করে? Greater wing আর lesser wing মিলে superior orbital fissure. Okay. So insertion in the upper eyelid, function হচ্ছে lid elevation. Okay. Main function is lid elevation. তার মানে দেখ, যদি এটা প্যারালিসিস হবে, there would be involuntary drooping of eyelids. বোঝা গেল কেন হচ্ছে? কারণ মেন কাজ হচ্ছে to elevating the lids, to elevating the eyelids. আর যদি ক্লোজিংটা করে, ক্লোজিংটা কে করে বল? Palpebral part of orbicularis oculi. Okay. So nasal groove, this thing already I told. There are four muscle: compressor nares, then dilator nares, then procerus and depressor septi nasi. So these are the four muscles. So procerus, it is present on the nasal bone and also the nasal cartilage. Nasal bone you have seen. Okay. And what is the function? It pulls down the medial end of eyebrow. So what is this kind of function? So actually making the vertical crease over the root of nose. Okay. And wrinkles the skin of the nose transversely during frowning. Okay. Now compressor nares, these things are not that much important. If you remember the name for your undergraduate level, that is enough. Okay. But in details you have to study what? First one is occipitofrontalis, then you have to study the orbicularis oculi and also the buccinator. Okay. These three short note, please you prepare. Okay. So these are the, I am just, so just see the picture. Okay. I am just skipping the slides, see the picture. So first one, this is what? This is the procerus. This is the nasalis. Okay. And what are the other thing you could see? See, this is the dilator nares. Okay. And this is the compressor nares. ঠিক আছে? And this is the depressor septi. So depressor septi is found on the below. Okay. So that is the muscles of nose. Oral group. Just make one snapshot. You don't have time to write, please have one snapshot. So what are the different oral group? Orbicularis oris. First one is orbicularis oris. Okay. Then lower group of oral muscle ki ache? Depressor angularis oris, depressor angularis, depressor labii inferioris and mentalis. Okay. Then upper group if you discuss, first one is rhizorius. Then second one is zygomaticus major, zygomaticus minor. Levator labii superioris, alkanizai. So I am talking about this, the most longest sentence of the muscle. এই মাসেলের কি ফাংশন জানিস? Levator labii superioris alkanizai. So whenever you are ignoring anything, okay, it is present on below the nose and also the superior lip. Right? So that is the muscle of ignorance. Write it down. Levator labii superioris alkanizai. Very much important. Muscle of ignorance. Okay, levator labii superioris alkanizai. And the last one is levator angularis oris. Levator angularis oris. So definitely it would be found on the angle of oral cavity. Okay. So see, this is the muscle. This is the muscle levator labii superioris alkanizai. So where you will see, it will arise from the frontal process of maxilla inserted on the ala of nose. Okay. And it is also to the skin of the upper lip by another slip. So what is the function? Please write it down. Function of this muscle. Last bench. Could you tell me the function? So this is elevates and everts the upper lip. Elevates and evert. Evert means you are taking the lip on the either side. Okay. Elevates and everts the upper lip and also dilates the nostril. Okay, so this is the levator labii superioris alkanizai. So you could see where it is present. This is the muscle. This one. Okay, from nose and the upper area of the lip. Okay. So now levator labii superioris, it is also present on the superior aspect and it is the muscle of sadness. Okay, so each and every muscle is concerned with each and every expression. Okay, now depressor angularis oris. Okay, this is also muscle of grief and also muscle of sadness. Okay, zygomaticus major and minor. These both muscles are concerned about the smiling. Okay, or laughing actually. Smiling muscle ke hobe jeta grinning bole, that is the rhizorius. Okay, write it down. The muscle of grinning. Okay, muscle of grinning, that is the rhizorius. Grinning. 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 Okay, and laughing is zygomaticus major, zygomaticus minor. Okay. So if you see this thing already I told, minor is above, major is below. You all know the zygomatic arch. ওপরে কি থাকবে minor, নিচে থাকবে zygomaticus major. Okay, so just I am coming over here the conclusion. So see over here this picture. So if you see, tell me the muscle name. এটা কি বল? Levator labii superioris alkanizai. So that means more medially কে থাকবে? alkanizai. তারপরে থাকবে levator labii superioris. তারপরে zygomaticus minor. What is modulus? Tell me something about modulus. Make one short note of modulus. Assignment for you. What is modulus? So this is the point of for the muscle to act. Okay, from origin and insertion. এবং মডিউলাসে কে কোন মাসেল অ্যাক্ট করে? The buccinator. Okay, because see, buccinator has got how many fibers? Do you know? 3 fibers. Upper fibers, middle fibers, lower fibers. Middle fibers are directly inserted on the angle of this oral cavity. But what about the upper fibers? It is going down. Lower fibers is going up. Where? This point, that is the modulus. Understood? opore dekh buccinator, if you see the superior fiber, it is going downwards and this fiber is going upwards. So this is nothing but the buccinator. Okay, so it is acting on the modulus. So this muscle we are talking about, that is the rhizorius. Okay, so this is the muscle of greening, then this is the platysma, and these are all depressor muscle. And along with the this one, this is the mentalis, which is situated on the mental protuberance of mandible. So have you seen, this is the greening, okay, that is the rhizorius. This is the spelling, okay, greening. So what is the function of mentalis? When you are flexing the chin, yeah, exactly that thing. So this is also known as, this is also showing some kind of sadness, okay. So this is the mentalis. Now coming to this auricle. So auricle you have written, remember these all muscles are vestigial muscle, okay. Last one is the platysma. Okay, so platysma origin and insertion is very much important, okay, for neck and face. So origin is the upper part of pectoral and deltoid fossa. কোথা থেকে অরিজিন নিচে বুঝতে পারছিস? ডেল্টয়েড ফসা, ডেল্টয়েড এন্ড অলসো দ্য পেক্টোরাল ফসা ফ্রম দ্য চেস্ট। ইনসারশন কোথায়? অরিজিন হচ্ছে থোরাক্সে, অরিজিন হচ্ছে থোরাক্সে এন্ড আপার লিমে। ইনসারশন কোথায়? অ্যাট দ্য বেস অফ ম্যান্ডিবল, দ্য স্কিন অফ দি লোয়ার ফেস ইনক্লুডিং দ্য লিপ। ওকে, সো যখন নেক ডিসেকশন করবি, ইউ হ্যাভ টু বি ভেরি কসাস অ্যাবাউট প্লাটিজমা। স্কিন পাবি, দেন সাবকিউটেনিয়াস ফ্যাট পাবি, তারপরেই প্লাটিজমা পাবি। ওকে, সো অ্যাকশন কি? হোয়াট ইজ দ্য অ্যাকশন? Releases pressure of the skin to the subadjacent veins, depresses the mandible, pulls the angle of mouth downwards. So many function, okay. So vein এর প্রেসারটাকে রিলিজ করার জন্য this muscle is acting. Okay, superficial যে ভেন আছে আমাদের নেকে, could you tell some superficial কি ভেন থাকতে পারে নেকে? Yeah, it is obviously external jugular vein because it is making one W over here. Okay, and another internal jugular vein where it is going to the jugular foramen, it is going to the brain. ঠিক আছে, তাহলে সুপারফিশিয়াল ব্রাঞ্চ যদি থাকে, কার ব্রাঞ্চ? এক্সটার্নাল জুগুলার ব্রাঞ্চ। ওকে, সো সেই প্রেসারটাকে রিলিজ করছে। ওকে, সো দিস ইজ দ্য ফাংশন অফ প্লাটিজমা। সো সি হাউ নাইসলি দ্য মাসল ইজ প্রেজেন্ট। ওকে, তারপরে দুটো পার্ট, এটা হচ্ছে তো ডেল্টয়েড পার্ট, এটা হচ্ছে পেক্টোরাল পার্ট, and this is the insertion. Okay, so that is the platysma. Okay, so now coming to the nerve supply. Okay, so there are two type of nerve supply, two not three type of nerve supply. Ki nerve supply ache bol face e? One is motor nerve supply, another one is sensory nerve supply, and another one is autonomic nervous. Okay, autonomic nervous system. So first one is, write it down, motor supply. Another 3 to 4 slide. Okay, hurry up. Another 3 to 4 slide. So first one is the Kiki branch ball motor nerve is coming from the 7th cranial nerve or facial nerve. Pasta branch. TZB, write it down. TZB MMC. TZB MMC. ছটা হয়ে গেল, কিন্তু এমএমটা হচ্ছে মার্জিনাল ম্যান্ডিবুলার। ওকে, টেম্পোরাল, জাইগোমেটিক, বাকাল, দেন marginal mandibular, last one is the cervical. Now coming to the buccal, buccal is again divided into upper buccal, lower buccal. Okay, so I am giving one assignment for you. All the nerve supply you have to find it out which muscle it is supplying. ঠিক আছে, সে অক্সিপিটো ফ্রন্টালিস থেকে প্লাটিসমা অবধি যতগুলো মাসেল বললাম, you have to find it out each and every nerve supply. ঠিক আছে, ফেশিয়াল নার্ভে কোন ব্রাঞ্চটা সাপ্লাই করছে, ঠিক আছে। So see this one. So first one is, it is going over here, that is the temporal nerve. Temporal nerve কাকে সাপ্লাই করবে বল? টেম্পোরালিস মাসেল কে কি করবে? ম্যান্ডিবুলার ডিভিশন অফ ট্রাইজেমিনাল নার্ভ। এই নার্ভটা কি? It will supply occipital frontalis এর কোন বেলিটা? ফ্রন্টাল বেলি। Only one. ওকে, দেন জাইগোমেটি কাকে সাপ্লাই করবে বল? দেখ দুটো পার্টে ডিভাইড করে গেছে, একটা কি the palpebral part of the orbicularis oculi, then this one is the levator labii superioris salicynosi and levator labii superioris, ঠিক আছে, and this is the upper buccal. Okay, so see what I told, this is the stylomastoid foramen. Okay, এখান দিয়ে কিন্তু facial nerve এসে parotid duct এইভাবে ব্রাঞ্চ করছে. ওকে, so this is the buccal nerve, this is the marginal mandibular cervical. Cervical কাকে সাপ্লাই করবে? প্ল্যাটিজমাকে. ওকে, now sensory supply, write it down. Sensory supply ভীষণ important, sensory supply. So sensory supply means what? Pain, pressure, touch, temperature, okay, of the face would be taken up by the fifth cranial nerve or the trigeminal nerve, and it has got how many branch? V1, V2, V3. That means ophthalmic, maxillary, mandibular. দেখ এটা অলরেডি লেখা আছে, ophthalmic is V1, maxillary is V2, mandibular is V3. Okay, so why it is important? Do you know where is the situation of trigeminal ganglion? কোন জায়গাটায় থাকে? Just pre-auricular area, just in front of the our ear, over here you are having trigeminal ganglion. ঠিক আছে, তার মানে এই তিনটে নার্ভ গিয়ে কোথায় রিলে করবে? ট্রাইজেমিনাল গ্যাংলিয়ন. ওকে, so why I am saying there is one condition that is known as trigeminal neuralgia. So what is occurring in this case? There will be excessive pain to this whole facial region. It may involve one branch or the 3 branch. So it is extreme painful condition. Okay, so see this is the 3 zone. Okay, ophthalmic, see that কত দূর অবধি ophthalmic বল? The whole area of the skull, and even what is this? This is the root of nose. So not only eye, also this nose, front of nose. Then see the maxillary area, the whole maxilla, and along with this is which bone? This is the frontal bone. Okay, and this is the last one, that is the mandible. So whole mandible is situated in the just in front of the trigeminal ganglion. So this is the trigeminal ganglion. বুঝা গেল? So here you could find another nerve, that is the autonomic nervous system. So which nerve is playing over here? কেন autonomic nervous system থাকবে এখানে? Facial region is there any secretion? Facial region কি? That is on the skin. That is on the skin. Lacrimal gland, tearing. ঠিক আছে, আরেকটা কি? salivary gland. এই দুটো সাপ্লাই করবে কি? অটোনমিক নার্ভাস সিস্টেম. ঠিক আছে, সো অটোনমিক নার্ভাস সিস্টেম. আর এখানে দুটো গ্যাংলিয়ন আছে, একটা হচ্ছে সাবম্যান্ডিবুলার গ্যাংলিয়ন, আনাদার ওয়ান ইজ ওটিক গ্যাংলিয়ন. ঠিক আছে, ইউ জাস্ট স্টাডি দ্য গ্যাংলিয়ন ওভার দ্য ফেস. গ্যাংলিয়ন ওভার দ্য ফেস কি কি পাবি? ট্রাইজেমিনাল গ্যাংলিয়ন, ওটিক গ্যাংলিয়ন, and also the submandibular ganglion. Okay, so next one is the clinical importance is the Bell's palsy. So Bell's palsy are of 2 type. Okay, Bell's palsy are of 2 type, upper motor neuron and lower motor neuron. Bell's palsy usually কোন টাইপের হয়? It is always lower motor neuron. Lower motor neuron. Have you seen any hemiplegia patient, paralysis patient? Have you seen? So what will happen if the stroke has been happened? Be quiet everyone. I am talking about very serious matter. Okay, suppose any stroke has been happened to one patient. Okay, so what would be happening to their limb and also their face? কি হবে? Suppose the area of hemorrhage or area of infarct on the brain on the left side, তাই তো, তার right side paralysis হবে. What about the face? It would be ipsilateral, means same side or contralateral. এটা ipsilateral হবে. কেন? Because এখানে ফাইবারসটা ডেকাসেট করার আগেই সাপ্লাই করে দিচ্ছে. বোঝা গেল? ডেকাসেশন মানে কি? যখন ক্রস করছে ফাইবারসটা, কর্টিকোস্পাইনাল ট্র্যাক্ট So before decasseting it is giving branch to the face. তার মানে তুই যদি দেখ লেফট সাইডে হয়েছে হেমারেজটা, তাহলে রাইট সাইডে প্যারালিসিস হচ্ছে আপার লিম অ্যান্ড লোয়ার লিম অ্যান্ড হোল বডি। ওকে, বাট ফেস you will see just below the nose there would be some problem. Okay, saliva is drooping from the angle of mouth. লিপের নিচে হবে, but above is upper quadrant is spared. Why? Because before decassation. বুঝতে পারলে? এটা একটু পড়ে নিবি। What is the difference between upper motor neuron and lower motor neuron paralysis? The difference between upper motor neuron and lower motor neuron paralysis. Okay, so what are the feature you will get in the Bell's palsy? Number 1 is drooping of eyelid, যেটা আমি বললাম ptosis, drooping of eyelid. Okay, first. Second one is dry eye is also known as xerophthalmia. Okay, xerophthalmia. Then the third one is excessive tear. So এটাকে কি বলে? epiphora. Write it down. epiphora. 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 Okay, then next one is the facial paralysis. Now tell me which side is affected over here? এই সাইডটা এফেক্টেড হয়েছে? So left side has been affected because this side is see no changes. ঠিক আছে? And another one is drooping of the saliva. Drooping of saliva. Write it down, the last one. So not only there is drooling of saliva, exact term is drooling. Drooling of saliva. Drooling of saliva from the angle of mouth, and also drooping of corner of mouth, drooping of corner of mouth, dry mouth, and along with impaired taste. Now tell me, taste is inside, na, means it is on the oral cavity, but how it is happening? Already I told, no, hypoglossal is the motor supply for the tongue. The taste sensation has been carried, আমি কি বলেছিলাম? Chorda tympani. Chorda tympani is a branch of facial nerve. বোঝা গেল? সেই জন্য you won't get any kind of taste. So this is the impaired taste sensation. Okay, so this is the another feature. Bell's palsy কিন্তু short note, long question, anything could come. ভীষণ important. ঠিক আছে? So this is, you see, ipsilateral, upper and the lower facial asymmetry. Same side, upper lower দুটো affected. Okay, কিন্তু হেমিপ্লেজিয়াতে কি হবে? শুধু লোয়ার পার্ট হবে। The face is divided into 4 quadrant. তো 4 quadrant এ পুরো লোয়ারটা ipsilateral সাইডে ইনভলভ হবে। Okay, so now coming to trigeminal neuralgia. Okay, so make one snapshot, this one, trigeminal neuralgia. So first one is the maxillary and mandibular nerve is involved. So see, the ophthalmic nerve is spared. Okay, then excruciating pain, that's I am saying excruciating pain or unbearable pain. Okay, in this region distribution of this nerve. Okay, and what is this? That is the Bell's palsy, that is infranuclear type of paralysis. Okay, so see, this is the thing, there would be pain involved in the trigeminal ganglion. Okay, so see, this is the treatment that we used to do. Okay, you have to decassate this nerve. কখনো কখনো এতটাই পেন হয়, you have to injure the nerve. Okay, so this is all about the face. Okay, thank you.